Yes, perfectly. We can hear you, Professor.
Okay, so this is what we're gonna do today. So we're gonna go, okay, over management of care. So I'm gonna explain like pretty much a little bit about that category in your NCLEX and how it works. And there is many students that are going to the NCLEX right now, and I have the feedback that is many questions on management of care. And in fact, it's really the category of the NCLEX that have the highest percentage, and the majority of the questions, okay, will come from this subject. So we're gonna talk, okay, pretty much about some on subjects, okay, some definitions that you need to know, and then after that, okay, we're gonna go over questions, okay. It's on there is some of the concepts that probably, okay, are like on really on misunderstood or really confused, and it's really important that you are clear, okay, before you go and we answer the questions together. Okay, so now really important, okay, what we're gonna do today, and out of time when I said to you, this is okay the way they will present it to you in your test. Keep it for your record. Keep it for your record because it will be like that. Okay, so now we go over the most important information about management of care, but it's really essential that you understand that I'm gonna give you examples, okay, of how those subjects will be presented in your test. Okay, and so the reason that you need to have all these definitions and concepts really clear, okay, in your mind, is because on NCLEX it's not we're still using strategies right now, but it's now a content test. So they really want to make sure that you know the concepts and the definition or everything. So a lot of times when you answering a question wrong in your NCLEX, you're changing the policy, and that's what they don't want to do. So they're gonna give you a license, okay, to practice your nursing, or in the first 6 months, practically on the only service you will be able to practice the first 6 months will be med surg, but they just wanted to make sure you're not gonna kill nobody, okay, upside after you finish. So, and that's the reason. So you will have many questions about management of care in your test, many questions about legal, many questions about priority. So we're gonna go over priority today. We're gonna go today over disaster, all these things. And then we're gonna answer, okay, like probably, okay, 100 questions together, okay, about all of this subject. Okay, so let's start. So when you go to your NCLEX website, this is, okay, what it means, okay, the management of care. Okay, so right there, it's going to include questions about ethical and legal issues, okay, advanced directive, confidentiality, on client rights, informed consent, delegation, priority, all these things. So when you look right here on in you are on in the first slide, so you will see, okay, how management of care pretty much it go from 70 to 23%. So as you look right here, is the highest percentage, okay, pretty much so you are, and it's 2018, but it's still now, okay, the same percentage right here, the same, it doesn't change. Okay, so I don't make a mistake, it's going now from 18 to 24, so which means even higher infection control, okay, it's increasing now to 70%, but it's still pretty much safety and effective care environment. It's the only, okay, category that include on the most higher percentage subcategories that will be management of care, infection control. So we're gonna go over management of care today. So next Friday we're gonna talk about infection control. Okay. And as you look right here, look, safety and infection control pretty much represents only 12%, but when we go to management of care, pretty much 20%. So it's the highest circumference, okay, right here in this PowerPoint. Now, do we have many questions about ethical principles? Okay, so we're gonna go over the most important only, okay, not on we're not gonna talk about all of them because I know you know this information, but the first three ethical principles you have right there are the most important one. So do we have questions about autonomy? Okay, many questions about autonomy. It's not as easy as you believe it is. Some of the questions are really complicated. And in autonomy means, okay, self-determination act. That's pretty much what the patient's decisions, if the patient is an alert and times 3 patient, as soon as the patient says to you, I don't want, okay, this to be done, I don't want, okay, to do this right now, you need to respect that. The deal is that most of the time in your question, they mention to you that the patient refusing something, and then we ask you what the nurse should do next, or what would be the first priority, okay, of the nurse. And that's really important, because after the patient refuses, the next step, it's not to provide an informed consent refusal, it's not to call them D, is to find out what is the reason the patient is refusing that treatment. It is, and even though the patient is refusing, they need to know the pros, the pros and the cons and the benefits, okay, from refusing that treatment. And then after that, the patient continues refusing, okay, we need to call them D. So we need to call them D to give an alternative treatment. Sometimes that will be between your answers, sometimes it's not. Sometimes the question is really tricky, in which the patient is not refusing treatment and is saying that I want that action to be done at lunchtime. For that, you don't need to call them D. And not refusing, okay, that right, I'm refusing that at this time, but I'm not refusing, okay, all the action as all. I'm just telling you, I want to take my medications, okay, at lunchtime before my wound care. That's it. That is not a complete refusing of action. When the patient says to you, I don't want to take the medication at any time of the day, so then we have to call the D to find an alternative treatment, because we cannot leave the patient like that. It's not only that you're refusing and, that's it. We don't do anything else. No, we need to find an alternative treatment for that problem, even though the patient is refusing that treatment. Is the patient okay and doesn't want to do a procedure? You need to do an informed consent refusal, and that has to be filed in the patient record and has to be documented. So you will have questions about that. If the patient is refusing surgery for some reason, be careful with this type of a scenario in your test. That is, in order for the patient to refuse any kind of treatment, they need to be competent. As soon as you give any anesthetic to patient, as soon as you give any medication that suppress central nervous system, I'm not talking only about anesthesia, I'm talking about benzodiazepines, I'm talking about antidepressant, I'm talking about medication for pain management. Any of these meds being given to patient 30 minutes ago, listen to me, 30 minutes ago, before the patient says, no, I cannot follow the patient autonomy. You're not competent anymore. You ready? Saying no to a procedure when actually you're mentally suppressed. And I have to continue with the procedure's schedule. So you see how one ethical principle can give you many scenarios. You have also the scenario with the patient, the medication was given right now, and the patient immediately 5 minutes after medication is given is refusing. No, now I'm evaluating autonomy plus pharmacology here. And any medication acts in 5 minutes unless the medication is given intravenously. If the medication was given intravenously before the procedure and the patient says no, I will continue with the procedure because that medication is making an action already. But if the medication was given PO or intramuscular, it takes 30 minutes to make an action to the onset of the medication. So I have to stop it. IV meds, as soon as I give it, you told me no, I will continue. PO, intramuscular, subcutaneous medications, okay, I will say no. It's just 5 minutes, okay, after it's given, I will stop it. More than 30 minutes after giving, okay, I will continue with the procedure. And that's really important. I always need to look at the time. I always need to look, okay, pretty much what is the patient refusing on that scenario. And that's really, really important. Not always we have to respect the patient autonomy. That only will occur when the patient is an alert and orient times 3 patient. So which is, it's a different monster. Got it? And the same when you're gonna give an informed consent to a patient, you must make sure that it's not under any central nervous system suppressant. No, it's I give you clonazepam for sleeping or for anxiety on daytime, and then I'm gonna give informed consent, it's not a right time to give an informed consent because that patient is not competent anymore. Because clonazepam make you drowsy. Opioid analgesics make you drowsy. So you're not competent. And this is what you have to look for. So you have to be careful. Okay, so you have to read carefully. And that's pretty much the best strategy here. Read carefully. Okay, there is many questions in your Nclex you'll be able to do it like this really quickly, but in the ones that are really difficult to you sometimes to understand what they're asking you, hold down yourself, okay, and read carefully. It's better to lose 2 minutes or 3 than answer the question wrong. Okay, the second ethical principle you have right there, it's very common too. And we say that the questions in your Nclex will be more related with the first 3. Okay, so the second one, nonmaleficence, is really common in your Nclex. The obligation to do or cause no harm to other. And this when you're stopping a medication known to be harmful, refusing to give a medication to a patient that is not being proved to be effective. This is the type of the question that you need to, the doctor order on certain medication to a patient, and you will see different answers right there. So one of them will be question the doctor orders. Okay, so is you know that the doctor is ordering medication, okay, that is it will be harmful for the patient, or it's not going to be effective according to the patient condition. Simple as that, you will question the order. So you will call the doctor back and you will question, is that patient, okay, will be discharged without criteria, and you approve the order, you're liable. So if the patient also has criteria to be discharged, so you have to question doctor orders, because you are approving an order that at the end will harm the patient. So it's really important. So it's not always that they're going to ask you, what is the ethical principle implemented right here? No, it's not like that. Sometimes they're asking you about those ethical principles you don't even know. They just give you the scenario and the answers. And they're not mentioning, okay, to choose ethical principles from nowhere, but you know it's related. So you have to be careful. And another one right here, it's pretty much, it's very common and is benefits. You must make sure that whatever action you will provide to a patient is going to provide benefits, as you can see right here in this example. And this is a question, okay, that sometimes you always, the majority of the time you see this question, you answer that question wrong, because the patient is not willing to undergo mastectomy because of fear of losing her feminine identity. So, and besides that, you will be in an ethical dilemma in what you don't want to have a mastectomy for your body image, but at the end you have breast cancer. So, and you are, what is the best for the patient, you know, of survive or body image. But we always need to respect patient autonomy. So it's nothing we can do. So at the end, if we don't respect patient autonomy, we are triggering harm to a patient. So I have to make sure that whatever, okay, benefits I will provide to my patient, it will be following patient autonomy. And that's really, really important. So right here, even though you know the patient in a mastectomy, if the patient says no, and the patient is an order times 3, the best for the patient will be follow what the patient is saying right now. There's nothing we can do. So we can see that, okay, pretty much in many, many questions, okay? Now, on not too much questions about this. Not too much questions about this. No, this one. Nursing Practice Act. So do we have questions about that in your Nclex too? Okay. So what do you need to know about Nursing Practice Act? Simple as that. That changes. Okay. Every single stage you go, it change. So it is. They're gonna ask a question that the nurse is going to move into another state. Okay, to work as a nurse. What is the first thing that the nurse needs to do? It's pretty much a research about the nursing practice out of that state, because it changed according to the state you live in at. And that's really important. So they're gonna ask you questions about that. So you need to know that always when you go to any state, United States, the first thing we have to do, pretty much is to know what is the nursing practice out of that state. So they will mention even from to where it's going on things like that. Standard of care, it's not the same. Standard of care, it doesn't change. It's like that across the board. It doesn't change. The same policy you follow for Foley catheter, the same policy you need to, okay, implement any stage you go, because the technique continue as the same to any stage you go. Okay, and that's really important. Now, the standard of care, okay, are the one that is published, okay, pretty much by board of nursing. Easy like that. The policies that you, okay, have in different places or institutions are the one that it's classified as an internal standard of care, and those needs to follow, okay, the extended standard of care that it's pretty much written by the board of nursing. How are they going to ask you that in your test? Easy, easy, easy. And if you see that the internal policy is acting in the patient safety, okay, it's acting against the patient medication administration. Like, for example, you have the policy in this place, a medication can be given 6 months, okay, after expiration date or from expiration date. So you know that according to the standard of care medication rights, as soon as the medication expires, you cannot give it. So easy like that. So you have two options right there, or you resign, okay, pretty much from the place, or you report her. And they're gonna give you those answers, okay, pretty much in your test. So which means wherever internal policy you see at the hospital or wherever you're working at, you must make sure it's following all the standard of care that is pretty much enforced by the board of nursing. And that's really, really important. If you don't follow that, we're gonna face a malpractice, and then it will be different monster. So at that time when they're asking questions to you about Foley catheter, okay, on when do you have to inflate the balloon, on with how many cc, and in what position you will place the patient, it's an steady procedure, it's not a steady procedure, that is a standard of care. So you need to know when they ask you about tracheostomy care, that is a standard of care. So you cannot change the steps. At the time when you're changing the steps, you're failing that question. And that's the reason, okay, this is not, okay, a nurse practitioner exam, it's a nursing exam, so you have to be familiar with the nursing procedures. And at a time when you are meeting on a step or you are action, okay, means that you are not following the standard of care. It's not that the Nclex will ask you about what is the standard of care, is that they're gonna, at the time when they ask you about transfer procedures, how do you can, okay, do this, how do you can do that, it's a question about the standard of care. So we need to be clear, okay, in those, because then we're failing, okay, part of the exam. That's not good. That's not good. How do you know you're failing part of the exam? Really easy. They're gonna ask you one question right now, you fail. They're gonna give you an easier, okay, question after that one, you fail. And then they're gonna give you another question related with the same subject you just failed. When I give you in the Nclex more than 2 questions or 2 questions about the same subject, you fail one of them. Really important, and that's an amazing strategy. I'm giving you, okay, a question on vaccination on children, and then I'm giving you two questions after that one that I failed. I give you another second question on vaccination. I know the first question on vaccination was failed. I need to stop myself. I need to hold down myself right there and try to answer that second question good, in order for the exam give you more chances to continue. Go on. So when you're answering questions about procedures and all these things, it's about a standard of care. So we need to know, okay, pretty much what it is. No. Hospital staffing, right here, I'm gonna go to flow. Do you have many questions about floating and delegation? There is only one study you have to follow with that. And always I'm gonna give the stable patient, okay, according to the Nursing Practice Act of that discipline, of that nurse, the most stable one out of times. What means floating? Floating means that it's a labor and delivery nurse, and I'm going from labor and delivery to med-surg. I don't know anything about med-surg, anything. So critical patients or med-surg cannot be my patients. Critical patients on ICU cannot be my patient because I'm a labor and delivery nurse. And that's really important. I will give you the stable ones. When I'm saying the stable ones, okay, you will think about universal skills of RNs, for example. What means universal skills? Intramuscular injections, okay, subcutaneous injections, do a wound care, give intravenous medication. But if you're a labor and delivery nurse, I cannot give a patient with a chest tube because you don't know how to manage a chest tube. You don't know how to manage, okay, pretty much a ventilator. You don't know how to give medications, okay, through endotracheal tube. It's not your expertise. So you don't know. So those patients needs to be with the ICU nurse. In med-surg, is I have a patient, what is the deal when they, okay, give you questions, okay, from labor and delivery to med-surg, that always in med-surg patient, they're gonna give you time. And whatever happened in the first 24 hours to any patient, that patient is unstable. So you cannot, okay, assign that patient to labor and delivery nurse because it doesn't make any sense. If you are within the 24 hours after surgery, no way. You're still unstable. So we don't know what is going to happen in the first 24. So I cannot assign that patient to labor and delivery. She doesn't know, or he doesn't know how to manage that. Okay, so, and that's really important. That's what we're looking in floating. That you can refuse to float? No. It's mandatory to float? Yes, it is. It's part of your nursing practice and you cannot refuse it. The only question they can give you in your test in which you can refuse floating is when you say, well, you are giving me unsafe patients, you have to change my assignment. I don't feel safe. And they have to change it. And you have questions about that. And answers like that the nurse is saying that change the assignment because I don't feel safe or my skills are not according to this level. All these answers are allowed. You are not refusing. You're staying by you saying that your skills are not on that level and you don't feel safe. That type of answer are acceptable to choose. And also, okay, pretty much always the questions most of the time will be about delegation and assignment in floating. Again, most stable patients. Okay, most stable patients. Okay, and what is most stable patient? Vital signs normal. And the patient is not, doesn't have any alteration on the level of consciousness or mental status, and pain management. Okay, pain management between 7 to 10 is considered and classified as a non-stable patient. So that patient cannot be assigned to patient labor and delivery. It requires continuous assessment. Okay, now from 5 to 7 is good. 0 to 5 it's good, but not from 7 to 10. So we have to be careful. We have to be careful. And that's the reason we have to read carefully when we're gonna choose an answer. And that's really important. And that's a very good strategy to know what patient is stable, which one is not. I'm gonna repeat it to you. Alteration of the level of consciousness, alteration of the mental status, vital signs and pain management. That's it, pain level. When I'm talking about alteration of level of consciousness, I'm talking about a patient that is in coma. Glasgow scale over the name, in coma. Okay, and when I'm talking about alteration of the mental status, is a patient that suddenly become confused. Well, you know, that patient needs priority. So we don't know. So you need to know. That's the deal that you need to know. Okay. No. No. Let's see right here. Yes, negligence and malpractice, really important. Okay. Now, do you know the difference between negligence and malpractice? On when you answering questions at home, do you see many questions about negligence and malpractice? Do you see any of them? I'm asking you.
Yes.
Negligence, yeah.
Okay, now what is the difference between negligence and malpractice? What are you? Just tell me something. What is the difference between one to another? Because they're gonna give you both answers in your questions. You know, they're gonna give you a scenario and they're gonna ask you, and they're gonna give you a letter A negligence, letter B malpractice. How do I know? Is that negligence or malpractice? What the main difference between both of them?
Negligence that if you do something
that you're not supposed to do appropriately, according to the standards, and malpractice is like you failed to do it,
Okay.
to fulfill your
Now,
duty.
negligence it's on malpractice applicable only for licensed people. Okay.
I know for sure,
My,
yeah.
yeah, malpractice not no one that doesn't have a license. It can be okay lawsuit for malpractice. It's only to licensed people. Okay. Unlicensed assistant personnel cannot be liable for malpractice. UAP, they can be liable for negligence. You see the big difference right there? So which means when I give you a scenario and you're talking about UAP, you never choose malpractice. Malpractice will be the RN in which that UAP is under supervised, but actually UAP will be on penalty for negligence, but not for malpractice. Negligence can be whoever you assign a responsibility, even though it has a license and is accepting that responsibility. You are a babysitter and you're gonna take care of my child, and I told you make sure my child is not gonna drop from your hands. Okay, and actually when I come back, that happened. You can be lawsuit for negligence, even though you don't have a license as a babysitter. You can be okay liable for negligence because it's a responsibility that you accept. But I cannot lawsuit that person for malpractice because he doesn't have a professional license. Got it? Besides that, negligence pretty much is when you forgot to do something. Yeah, that's the main difference. When you forgot to do something. Malpractice actually when you have a license, people, and you omit or you fail in what you're doing. Because you don't have to know knowledge, okay, because you don't know how to do it and you do it for all these things. So when they give you the scenario, always look, okay, about what people it's including that scenario, what discipline it's right there. It's not always malpractice. Got it what I'm saying? Understand?
Yes, prof.
Okay, now do you like it the way we're doing it?
Yes, yes.
Okay, you feel good, you feel engaged.
Yes, of course. Yeah, yeah, yeah.
Perfect. Okay. Just to make sure. I don't want anyone sleeping. Okay.
No, no.
Okay, with me that's different. That's difficult, but anyway. Answer of with many questions about all these things. Now, good Samaritan law, it's always in your test. Not so frequently right now, but whoever is working in medical centers need to have a CPR license. You know that. Now, good Samaritan law was the deal that never and ever they're gonna give you a scenario at the hospital. Good Samaritan law, it's the kind of the law that we use it only in type of situation that occur outside the hospital. And we're talking about the always and the same question and the same example in your Nclex. Okay, never change. Just remember, 36,000 okay bound questions in your Nclex. A lot many questions that change the format, but the content continues the same. Okay, so which means they do that randomly, but at the end, the content continues the same. It's still some of the procedures and techniques. We are not doing that anymore, but it's in your ankle, so you need to know. So that's the way it is. Nothing we can do. But good Samaritan law means that you're just giving CPR to someone outside, and that patient, okay, has a rib fracture, a fragment of the bone, punctured lungs, and the patient went to ICU with a pneumothorax and needs to be intubated. After the patient's okay out of the ICU, the patient says, "Hey, I'm gonna sue you. I was in ICU for 2 weeks." Well, is you actually as a nurse, you are able to prove that you follow okay the CPR steps. We not meeting any steps, just following all the procedure, and you don't receive any gratification from family. So I'm just talking that you cannot accept anything from family members. No, and never, because that will be the price of your action. And if that happen, we cannot apply the immunity Samaritan law to a patient, I mean to the nurse, because you already accept a gratification from your action. So if I give you $5, that's the value of what you do. So I cannot do anything okay to save you. Which means who applied for good Samaritan law? The nurse that never omit any step during the procedure, and the nurse that never accept a gratification, okay, from the family member or anyone. So pre-fractures and expected complication from CPR. Is whatever happened is expected from your procedure as a complication, no problem. We can implement on a good Samaritan law to this nurse. Now, how are they going to ask it on your Nclex? Which of the following statements can be on whatever we can use the good Samaritan law? Celero that apply. So they're gonna give you 5 statements, and you have to look and check for the statements that in which each statement we have different scenario. So we need to know in each of them is that okay law can be applicable on it. But just telling you the strategy. It's only 2 important steps right here. That you don't meet any step in your procedure, your technique, and the second one is that we never have set a price for that action. Okay, no, the price will be that if you fail, okay, we can use that law to give you immunity and you don't lose your license. That's pretty much what it is. Okay, now they're gonna give you questions about pretty much on, we're talking about the law, about the civil law. That is the kind of the law we implement in nursing. Okay, we're talking about torts, and the torts, okay, it has 2 important branches right there. One of them that is intentional torts, another one that is non-intentional torts. Non-intentional torts, we are talking about malpractice and negligence. We already go over that. Intentional ones are the ones that we know what we're doing. We know what we're doing. So we have to be careful. And assault means when you're actually talking to someone and wherever you're saying, okay, it sounds like a threat for that person feels intimidated when you're talking. Okay, you're not actually, okay, hating anyone, but when you just mistreat a patient verbally, that would be an assault. Okay, there is not so many questions about this. There is question in your test that is talking about when you go to side question, there is a question about patient, family, psychobalance. Okay, and the only thing they wanted to know is the steps. And we have the assault is the first step. The second one is battery. Okay, and the third stage will be, okay, honeymoon. So in other words, I'm screen to you. Second, I will make you purple from head to toe. And then, okay, the third level is that after I make you purple from head to toe, that I hit you everywhere, we're going to go for dinner. We're going to go for dinner. That's the 3 steps, which is, I mean, it's something that we have to deal with in nursing. So questions about assault, okay, will be when they're gonna ask you questions about how you can identify an abuser. Yeah. So in other words, again, you're not touching anyone, but you are using a tone of the voice in which people feel intimidated sometimes. Okay. Battery, it's not always that you're hitting someone. Other times when the patient says to you, no, 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 I don't want that procedure to be done, and you continue doing it, you are touching the patient body right now without patient authorization, and that is battery. And that apply only for the procedure that doesn't require any kind of anesthesia or something. Like for example, when you're putting an enema to a patient, and when you're inserting an enema and you're giving an enema to a patient, the patient says to you, it hurts what you're doing, it hurts, and you actually continue doing it, that is battery. That is battery. You're touching the patient right now without patient authorization. I'm gonna do a wound care. The patient is in pain. I don't want to do the wound care right now. No, but I have to go. And you do it, that's battery. I'm not giving you consent to touch my body right now. And that's battery. Invasion of privacy, it's many questions on invasion of privacy, many examples. You have examples of nursing students on going, okay, on for an in-service on our follicular insertion, and actually the patient needs authorization for 11 students, and then you go with 12. Now you are acting in invasion of privacy. I give you authorization only for 11, okay, to look my things, okay, for insertion on the follicular, not to 12. Invasion of privacy means elevator talking has to go. Elevator talking has to go. And that question is really common in your Nclex. in which is two nurses go to the elevator, start talking themselves, and they have the family member, okay, behind them, and they're talking about a patient. You see what happened in room 202? Oh my goodness, a big argument between the wife and the husband. And you see the family member, okay, behind the nurses, listening, everything. That's invasion of privacy. Information over the phone, that's invasion of privacy. You don't give information to no one over the phone because you don't know who's that person. You will say to the family members, you need to assign a spouse person, and the spouse person can talk to me, but I cannot talk with every single family member every 5 minutes about the same patient. So okay, and you cannot, because that would be confidentiality, HIPAA, but it's also invasion of privacy. And that's really important. So and you will see questions, like about that, and so many questions about that. On invasion of privacy, photograph, okay, videos without authorization, very common. Invasion of privacy, when that's very common question in your NCLEX, in which is you see two nurses talking about a patient in the cafeteria. So you have two nurses taking a break, they go to the cafeteria and start talking about a patient. And there is a third nurse who arrives to the scenario. What the first action? What is the highest priority? And the highest priority, when you see two nurses talking about anything confidential in public, you need to confront those nurses. The answer is not reporter, you run. At the time I'm reporting you, I'm allowing those nurses to continue talking in the public space about something confidential. Confronting that action, which they will say, hey, can you go to a private place so you can continue discussing, okay, about that patient situation in other area, but not in a public space? That is confront. Then after that is the one you can report her. Of course, we're gonna report her, but it's not the highest priority. It's not the initial action. And that also is a mention of privacy. So we need to know. They're gonna ask you questions about that. False imprisonment, the questions about false imprisonment in your NCLEX is always and always, okay, about restraints, okay? And when we're talking about restraints, okay, how it is, you know what it is? Okay, pretty much, we cannot have a patient restrained without doctor orders. We need to have, okay, doctor orders that says how long you're gonna keep that restraint, how many minutes you're gonna relieve that restraint. What is the reason you are putting that restraint on? That is really important. When actually we're restraining a patient without doctor orders, that will be false imprisonment. Okay, and you have to renew that only every 24 hours. Now, question, really tricky in your NCLEX. In psychiatrists, I will ask you one question, that we need to have a doctor or psychiatrist order to restrain an aggressive patient?
Yes.
Can you hear me?
You mean that the patient suddenly gets violent?
So aggressive and violent, I want to hurt someone and himself too.
Hmm.
They will
Yes, you
need a
can apply.
psychiatric orders. Huh?
Yes, you can apply a restraint, but you have to make sure you get an order from the doctor right away.
But what do you do first? Do you call the psychiatrist for an order, or you restrain the patient?
I believe you can go ahead and restrain the patient if he present like.
Perfect. Now, this is the question in your NCLEX. How many hours do you have to have a psychiatric orders after you restrain a children and after you restrain an adult?
Less than 24 hours.
2 hours for children, 4 hours for adult. Okay, you renew it every 24 hours, but not because you're in psychiatric services, you have to make sure you will contact that psychiatrist or 2 hours after restraint, okay, being placed for children, 4 hours for adults to back up your order, your intervention. Got it? Understand?
Yes.
That's really important. If we don't actually do that, if we don't renew the order every 24 hours, we are in false imprisonment. We are keeping a patient right there, restrained with not act orders at the end. The time expire. Now it's a false imprisonment. When you actually give and you see some of the scenarios, okay, or the patient says, I want to see my baby, I want to see my baby, and actually the patient is a dementia Alzheimer patient. I want to see my baby, I want to see my baby. And then the nurse take a PRN Xanax for another patient and give it to that patient to have the chief quiet. That is a chemical restraint. And it's another false imprisonment. When you actually, okay, give any medication to keep the patient down, calm down, without doctor order, it's a chemical restraint. It's not allowed. And another thing is that there can be a penalty for false imprisonment. Okay? Now, defamation. How are they going to ask you defamation? You have two type of defamation. Sorry, slander and libel. Slander was actually any statement can be given verbally. Okay, and libel pretty much when any statement can be written. So now, cerebral applying. I see, I I've been giving this review for many years, and that I always as student give a feedback. Hey, teacher, I passed the Nclex. Okay, this is what it was on my exam, and there is many there is questions in your Nclex in which is a well, okay, ask you which of the following statement is an example of slander. Cerebral apply. So you need to know that slander means verbal statement and libel means written one. So written statements. So you must make sure what you're gonna say about someone. Not in is, I mean, 100% of your statement is true. And it takes time to all of us to learn that. But 99.9% of your history is true, 1% it's wrong, you can be penalty for defamation. So you must make sure 100% of the statement it's true. So and they're gonna split, okay, that defamation into a slander and libel. So you must make sure that you cannot choose a libel for the slander in your cerebral apply because your question will be wrong. And this is how they're gonna ask you that in your test. Okay. Hope this one is really common. Safeguarding valuables, okay, mean patient belongings. Okay. So we have many questions about that. Talking about hearing aids, dangers. We are talking about, okay, on patient belongings, in other words. Now, any kind of valuable on pertinences from patients, we cannot hide it in a medication card. We cannot hide it in a station. We have a safe box at the hospital that pretty much we use in order to lock, okay, on any of this precious on pertinences or belongings from patients in order to keep it safe. Now, it's not the first intervention. The first intervention will be, do you have any family member that we can call to take this back home? We're gonna keep it in the hospital. Okay? And then they will mention in your question about jewelries and watches and all these things. We always ask the patient, do you have someone can pass by and take this back home? You don't have anyone? Okay, we have to put it in a safe box. Okay, but the safe box is it's an area of the hospital which is we lock that. We don't use medication, card, narcotics, anything like that. We cannot mix medications, okay, with those belongings because it's not good. A lot of times when the nurse or CNA or UAP is gonna manage the patient belongings, or we have to make sure that we have a document which the patient is gonna sign and give you the consent, or the caregiver or proxy is gonna do that for you. It's really important. We cannot manage the patient belongings without patient authorization. Why? Why? You have many questions in which is you are you're fixing the patient belongings and suddenly amphetamine bottle drops on the floor. You will say, what? What can I do now? I don't sign the document for the patient giving authorization to manage the patient belongings, and now I'm an amphetamine bottle on the floor, so they will know I'm doing that without consent. That's the reason. What do? So you have to report it. You have to report it's a control system. You have to report it. And sometimes they even mention in your Nclex that amphetamine bottle doesn't have any label, so we don't know who prescribed it, we don't know from where it's coming from, but it's there. So it's really important. So before we go and manage patient belongings, we always need to sign a consent that the patient is giving us authorization to go and manage the patient belongings. And that's really, really important. Okay. Now, two scenarios right here. It's actually the amphetamine bottle have the doctor's phone number. We always ask the patient the reason that medication was prescribed. And second of all, if there is no label, it says only amphetamine or the name of the medications right there. Okay, when it's code tape and it's no label, we have to report it. Two different scenarios right there, according to what you see. There is many questions about cultural values and belief in reference to wedding bands and things like that. It's when you have religious, middle scapulars, things like that, you must make sure that is the patient going to have surgery and they have this wedding band and they have this middle scapulars, on, and they say, no, you cannot remove it. It's important to me, to have this on for surgery. We cannot say no. We have to tape it completely, but patient needs to sign a paper that in which we are not responsible to whatever happened to the wedding band, middle and scapulars after tape is removed. But we cannot refuse it. We cannot ask the patient not to have it on. Mostly is that have an important and religious meaning to the patient. So there is many things we do in real life that is not applicable for your exam. So we have to be careful. But that's the way you have to proceed. Prescription orders, that's another thing right here. It's really easy. So you must make sure when you don't understand, on any order given on over the phone, you always have to call the doctor twice and clarify that order. That's really important. So they will say, they will ask with the following doctor orders, needs to be questioned or needs to be challenged. They like to use that. So you know that all prescription need to have date, time, medication name, dose, route administration, frequency, and of course, who's prescribing it. If I actually see any of this, on answers that include any of these elements missing in the prescription statement, I will say that is a type of the order that needs to be questioned to ND because it's missing information. They do that sometimes. Which is the following, doctor order needs to be clarified immediately. There's another thing. So you need to know. You need to know. Client family teaching. I will say that questions are difficult. Now, I'm going to ask you something. Nclex question. Let's say that now you have a patient with hearing aids. A patient is deaf, is using hearing aids, and you're going to teach the patient about medication treatment. Which one requires the highest priority? Actually making sure the hearing aids working properly or readiness to learn? Between both of these answers, which one has the highest priority? Readiness to learn or make sure hearing aids are working properly? Difficult, right? Whatever comes to your mind, just answer to me.
I'm not sure, but readiness to learn.
Now, I'm gonna ask you one question. We're doing this together. On how I will be ready to learn is actually my disabled device not working properly. Readiness to learn, it's not talking pretty much about devices, talking pretty much about patient cognitive level. It's talking pretty much, okay, about how much the patient is prepared to understand what I'm gonna say to you. So barriers to learning, language, and things like that. But if you actually are a deaf person and the hearing aid is not working properly, you won't be able, okay, to be ready to learn because you won't be able to understand or listen what I'm saying. When you have patients with devices, and let me tell you something, glasses is a device. And actually, I'm giving a material for the patient to read. So I have to make sure the glasses are clean. I have to make sure hearing aids are working properly. That will be my first priority. Then after that, okay, I will go to readiness to learn. Okay, what kind of language are we use? What kind of material are we use according to the patient, you know, on a learning level or cognitive level? That's pretty much readiness to learn. How much, okay, knowledgeable can be that population to understand what I'm going to explain, what language they speak. Got it? So, but devices always go first. Always. Got it? That's really important. It's really important. So we have to make sure we're gonna teach family now. Really, really easy. What is the best answer to you? To teach the patient only or teach patient and family and caregiver? Teach patient and family.
Yeah.
Yeah, because family at the end is the caregiver. So they're gonna give you both of them. Teach the patient about this, the same answer. Teach the patient on side effect of certain this medication. Teach patient and family about this medication. So you have two statements talking about the same med, but in on one statement is talking about the patient and another one is including the family. Always include the family in your teaching. Always. Because a patient is not competent for some reason, is becoming probably temporarily disabled. So the family will be the caregiver. So we need to explain to the family. Now, let's say that now the patient wants to speak English. One question, family members can be interpreter to
No.
translate? Yes or no?
No,
No,
okay,
Okay.
just translator from the hospital.
Perfect. You need to have a person from hospital. Family members cannot be an interpreter because we don't know. Okay, what's the intention? To be honest, that's the reason. That's the reason. And you always have to document wherever it was teach. Okay, that's really important. You have many questions, okay, about that. Now, what kind of keywords the Nclex use for teaching the word reinforce? And let me tell you something. Okay, when you want to reinforce something, okay, it doesn't mean it's wrong. And when it's from the nursing part, look how it's that keyword managed. When on the question is on talking about a subject that the nurse needs to reinforce, you always will look for the positive statement. Okay, which is the following statement the nurse needs to reinforce during discharge. Okay, whatever, you're gonna reinforce all beta blockers, but you don't need to choose a statement when it's talking about the nurse about something wrong about beta blockers. No, you're reinforcing beta blockers because you want to make sure the patient will understand better before going on about beta blockers. Okay, that's one side of the coin. The another side of the coin would be, which of the following patient statements needs to be reinforced? So patient statement that needs to be reinforced is because that patient statement, okay, said something wrong. It changed completely. It's not the same. You want to reinforce subject during teaching because you're talking about that subject, okay, to the patient. And you want to give more information about it, making sure if we have the clear and the more concise information before going on. But when the patient is stating something and that statement needs to be reinforced, I will look for the wrong statement now. Two different type of questions with the same keywords and two different answers. So we have to make sure. Do you understand? Do you understand?
Yes.
Good. So that's the reason I have, okay, to read carefully. Don't rush too much. Don't go so slow, but also take little time to at least, okay, read the subject of the question and to identify what they're asking you. That's really important. Impaired nurse, okay, what you need to know, okay, pretty much in reporting responsibilities right here. That's really important. Communicable diseases. You know that we follow HIPAA, and we're talking about HIPAA. That means that information cannot be disclosed. But there is many information that needs to be disclosed, but needs to be disclosed to the right agencies. I am talking about STDs, including HIV, including animal bites, like snakes, like wherever, like on the thick bite. All these things needs to be reported immediately. Any kind of abuse, any kind of neglect, any kind of gunshot, any kind of stab wound, assault, homicide, suicide, all these things needs to be reported immediately. Immediately. That information cannot be kept for you. So at this time, I'm sorry we cannot keep that information close. We have to disclose it. But we're going to disclose it to the right people. It's not to everybody. And that's really important. When we have a communicable disease, we need to report it immediately to the health department. When we have any bite from animal, okay, the first intervention will be patient first. Patient first, limit the area, and then reporter. So you're gonna limit the area because you don't want anyone else, okay, pretty much getting into that area being danger. And then we'll reporter. And that's the sequence, okay, for animal bites. Okay, it's really important. But patient first in referring to assessment, in reference to tourniquet if that is required, and in referring to antidote we have it on hands. Okay, that's really important. And in referring to abuse, patient first. Patient first, always. Assessment, okay? And when we identify any kind of abuse, we have the abuser or we suspect the abuser is the family, we interview the family first. And then after that, we report to the police and authority. That's really important. That's the sequence. Impaired nurse. You have questions about that in your Nclex. What's the trick of the question? Keep it for your record. I told you at the beginning, all these things will be presented to you in this way. Remember, out of time when we have a nurse that becomes impaired for some reason, because they're using drugs or they're using something, and they see the board of nursing look at these people as a sickness, as a sick people, as a situation that can be fixed probably. The board of nursing doesn't remove the license at all. Pretty much they're gonna enroll this nurse in a prevention program, but that will happen only when you as a nurse go to the supervisor and says, I have a problem, I'm abusing narcotics, I have a problem, I'm so sorry. Well, they will report it to the board of nursing, you will be in prevention, okay, but actually the supervisor catch you doing something wrong, they're not gonna report you. They're not gonna report you to the board of nursing as an impaired nurse. Okay, they will report you, okay, pretty much as a criminal activity. And probably, okay, that license will be suspended and never revoked. And that's the reason Okay, and when the nurse identify they have the problem and they report themselves, they will be part of the prevention program. Now, what the tricky question right here? How many years is that prevention program? Do you remember? How many years is that prevention program for impaired nurse? Whatever time comes to your mind, let me know. Tell me something.
A year?
2 years. 2 years. And the reason I'm telling you that, because look the trick of the question in your Nclex. Look how they're going to ask you this. Look. The first thing I will tell you is that as soon as they classify you as an impaired nurse, you can never and ever touch narcotics for 2 years. You can continue working as a nurse. You will be in a prevention program, but you cannot touch narcotics anymore during those 2 years. And if the patient needs a narcotic, you need to find another nurse that will give it. And that nurse will sign, and you will consign that nurse signature when actually the patient is not in that nurse assignment, but you cannot touch the narcotic. What the Nclex do to you, they don't even mention years. They will give you a number of weeks or months.
But also she cannot administer? Sorry, Professor.
No, not administer, not touch it,
Okay.
not nothing, not take it for medication card. No, 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 no. All the nurse has to do it for you. Yeah, that's the way it is. What the Nclex do, okay, that we say in your question. The nurse being screened for 6 months after being in impaired, okay, nursing program or prevention program, or with negative findings, whatever. And even they can tell you 1 year and a half on 22 months, that is actually almost 2 years. No, even you are 22 months clean with negative screening, you cannot touch a narcotics until full 2 years. Until full 2 years. At 2 years, okay, that will be reported to the board of nursing that you've been clean and negative screening for 2 years, and they will remove that tag from your license. Until that doesn't happen, you can continue being away from narcotics.
Professor, I got a question.
Sure.
Okay, so just to make sure that I understand. So for example, if a nurse is impaired, you're saying that they will still keep working for that 2 years?
Yes.
It's not like stop
Yes.
working.
Yes.
Keep working. Okay, the only thing is that you will not be allowed to touch anything. Is that correct?
Narcotics, not anything. Narcotics.
Okay.
Controlled substances.
Okay.
But the question
Thank you.
would be that, you know, they're gonna give you a scenario that the nurse, okay, behaving really good for almost 22 months, okay, almost 2 years, and then it's a patient that needs a narcotic. What's your answer? No. They have to wait for the full 2 years program. Understand?
Got it. Yes.
That's the way that we ask you. So and you know, you would say, well, you know, that's nurse is good. It's behaving good. What is it gonna get a narcotic? No. Don't change the policy. No. You will be wrong. Okay? Very
Okay.
tricky question, but it's like that. So you must make sure, okay? Right here, occupational health, safety and health. That is in reference to OSHA. So, okay, all of us were clear on that. On sexual harassment, as soon as you see any kind of sexual harassment, it has to be reported immediately. Any unwanted behavior, that's to be reported immediately, because that would be an abuse, okay? Advanced directive, we have questions about that. Where we go now, living will. So now I'm gonna ask a question. Nurses can be witness of living will, yes or no?
No.
I would
No.
think no.
No. No. When we are going to use the living will, when the patient is no longer able to make any decision. Okay, I would do the living will where I'm actually an alert, an orient times 3 person. Okay, and I will stay on that living will what I don't want to be done with my body when I'm not actually able to make any decision by myself. It's actually the patient is an alert and orient times 3. Why do you want to use that living will? No, I will go and ask the patient. Okay, what's the reason you want to use that living will? You put it in practice when actually the patient is still able to make decisions by themselves, herself or himself. So I will use it only when the patient is no longer able to make any decision. I will respect it. Okay, nurses never and ever can be witness of living will. So do we have some questions in which is the patient was just diagnosed with earlier stage Alzheimer and wants to do a living will. Nurses can be witness of living will? No. No. At all. Okay. Head chaos over a proxy, okay, means that you will assign someone to be a proxy. That can be a friend, it can be a family member, it can be a brother, a sister, a son, daughter, whoever. That would be your proxy. Means that that person that is your proxy is the one in charge to make decisions about that patient health situation, health condition. Okay, in behalf of the patient, no one else. Even though a friend is a proxy and they have a son and their daughter and they don't, okay, assign this son and daughter as proxy, a proxy is a friend. That friend is the one that we have to call to make decisions, not son and daughter. I don't decide my son and daughter to be my proxy. I decide that my friend will be my proxy. Well, that's the way it is, you know? And that's okay really important because they have questions about that too. Okay. DNR. DNR. And on a question about the patient getting to a emergency room with a tattoo that says I'm DNR. What are you gonna do? Is that tattoo really valuable to you? To not resuscitate the patient?
No.
Good. DNR expires. DNR expires usually every 1 year we have to renew DNR. That DNR need to have adopted orders. Yes. Don't make that mistake because I see a student make a mistake that no, they doesn't need to have adopted orders. Yes, need to have adopted orders. The one who starts, okay, pretty much the DNR, it will be a doctor. We need to write doctors need to write an order that says DNR. Family member can sign the DNR, but it's actually there is not a physician signature. There is no DNR. DNR requires a physician signature. It's not included. That patient is not a DNR. It's not valid. So we have to make sure it's renewed. We have to make sure it's in a yellow paper. We have to make sure it's filed in the patient record. Okay. And that's pretty much what it means. Okay, call patient. So you must be careful. So when we're talking about DNR, I'm talking about not electric shock, not positive inotropic medication. So do you know what it means? Positive inotropic medication, right? That's very tricky in your Nclex, so we need to know which ones are. Pretty much on whoever medication increases, okay, the heart rate, all of them are classified as a positive inotropic medication. I'm talking about duvotamine or duvotamine. Okay, it's an example. So that, okay, will be kind of resuscitation too. And intracavity chest injection, talking about adrenaline, okay, intracavity to patient, no. No, that is also resuscitation, electrical shock, CPR. you know. Now, oxygen, it's not a method of resuscitation at all. It's someone die and you put oxygen, okay, you put that person in oxygen, it's gonna continue death as it is. It's not gonna go back. Okay, so oxygen, yeah, can be given to patients with DNR. That's not a problem. Give oxygen to DNR patient. That's not a problem. But the ones I just mentioned to you, no. No electrical shocks, no intracavital injections, okay, no positive inotropic medications, no CPR, no endotracheal tube. That is another one we use, okay, to resuscitate the patient. Those are not allowed in patients with DNR, okay? That's really important. Well, this is HIPAA, as you know, so we know we cannot, okay, on disclose any information. We always have to keep the patient on PHI, on very much confidential patient health information and this is really important. This pretty much are the kind of the situation that requires most of the time on disclosure. Okay, and so we have to pretty much report it to the okay and appropriate agencies, but it's most of the time the one that we discussed before in referring to abuse, okay, in referring to drug addiction, okay, kidnapping, manslaughter, okay, things like that. That has to be reported. Okay. Uh, referring to confidentiality is that we always have to keep the patient information confidential. So electronic and medical record, it's really important right here. It's part of HIPAA too. And just remember, okay, and most of the time that we try to concentrate more your attention in your test in hospital settings. And in hospital settings, we change the password every 30 days, okay, pretty much. So you must make sure that password never can be shared with anyone else, and you must make sure you cannot steal someone's password to log in other nurse computer or other nurse assignment that is not your assignment. So you have questioning, which is a nurse who discharged a patient 2 weeks ago and he was in contact precaution, see that the patient is readmitting, okay, 2 weeks after in other assignment. So the nurse tried to steal the another nurse password in order on for the patient behalf, something like that. It's a question similar to what I'm telling you right now. No, you cannot. You cannot, even though you believe you're doing something good for the patient, you cannot steal anyone information, okay, to just believing you're doing something good. We cannot keep the screen open. Okay, we cannot, okay, leave on papers in the fax machine. We cannot leave, okay, on patient records open in a counter. And all this, we cannot fax any paper without a fax cover sheet. We cannot call the family member and leave message. No, we cannot leave a voicemail to the family member saying we are calling you regarding your mother that is in second floor in 202. We don't do that. We don't know who's gonna listen that message, so we don't leave this type of message in a voicemail because it is a HIPAA violation. We don't page or overhead any patient information. We don't do that either. That is confidentiality. That is HIPAA. So we have to make sure. Okay. That's really, okay, really important. And you have it right there, invasion on privacy. That's really important. So leaving the curtains open in a room, okay, very common. So what about with a room that have two beds? If you're gonna discuss that information with family members and you have on patient letter A, patient letter B, you need to take that family member out of the room and talk to them about the patient situation. You cannot do in when actually the patient in letter B is listening what you're talking with the family members of letter A. It's not good. Okay, when you're leaving a patient confused and agitated in the hallway, that is invasion of privacy. We cannot leave confused patient and agitated patients, okay, pretty much in the middle of the hallway. That's really important. And let's see what else. We talked about that already. No. Informed consent, really good. You have many questions about, okay, informed consent. And informed consent is really important. And Informed consent means that actually you're going to explain that consent, the procedure to a patient, and you must make sure the patient is competent. You must make sure the patient is not under sedative or any other medication that affect or impair the patient cognitive abilities or skills in order to sign that consent. And that's really, really important. And in referring to minors, you must make sure, okay, about parents. We're going to talk about that right now. Informed consent required to witnesses, okay, you need to file in a patient record. And we need to describe also in our documentation what is that informed consent about it. And that's really, really important. Now, you have different type of informed consent right there, and that's really important. Now, admission agreement, informed consent, is when the patient gets to a hospital and they sign an admission agreement in which they give you authorization as a nurse to touch the patient for routine procedures. I'm talking about oral, okay, medications. I'm talking about intramuscular, subcutaneous. I'm talking about routine care. Now, one question for you. Is the patient need an opioid medication? That patient needs an informed consent? Let's say you're at the hospital right now and you actually have a strong pain. I need to give you morphine. Do you need to sign an informed consent for that? A different one? Yes or no?
No.
Yes. Yes, because opioids are not part of your routine care. No, it's not. It requires an informed consent. Immunization requires an informed consent. Blood transfusion, even though you sign an admission agreement, requires an informed consent. Really important that it's not classified as part of the routine activities. So, and that's the reason, patients are admitted and it becomes complicated. They upgrade to another level of care. And that's the reason, as soon as it becomes more complicated, okay, most of the time, either way it's supposed to be, either they need to sign informed consent for other interventions. Chemotherapy, radiotherapy, that is not part of routine care, also needs an informed consent. Okay, and blood transfusion needs one too. Surgical consent needs to have an informed consent too. Research informed consent, and a special consent for restraint, photography, on dispose of the body parts, donation organs, and autopsy. That's really important, so we need to know. Okay, so means that in the legal guidelines, you must make sure that at the time when the patient have any mental illness, like Alzheimer's, dementia, something is affecting pretty much the patient's mental competency to sign an informed consent, the legal guardian needs to sign. Okay, and that legal guardian needs to be appointed by the court. Okay, and that's really, really important. A competent client older than 18 years of age, that would be a competent client to sign by himself or herself. Okay, and we always need to explain everything on the procedures, okay, complications, okay, benefits, all these things. Now, what about minors? And when do you classify someone as an emancipated minor? Which ones are the criteria for emancipated minor?
When they are married
SED,
or pregnant,
Pregnant, what else?
S
married,
Married, what else?
When they have STDs,
Mhm.
When they have, okay, STDs, what else?
Professor, what about when they're raped? Is that one of them or no?
When they rape,
Yeah.
no,
Okay.
no, they're not emancipated. No. When they are serving in military forces, yes. When you're pregnant, yes. What about after delivery? Are you emancipated? You're emancipated during pregnancy, but what about after delivery? You are not emancipated. You're emancipated during pregnancy, but after you had your baby, it's still your mother is you are under 18 years of age, make decisions for you. Yeah.
And for the baby too?
And for the baby too. Yes. You have right there, and you have emancipated letter from the court saying that you are emancipated. That's really important. When you marry, but you marry, and you must make sure you're showing that the person is marrying you is supporting you. But if you marry, but if that person is not able to support you in all your needs, you're not emancipated. So you have to, okay, prove, you have to show me proof of income, making sure you are married with someone in which is you need to be covered. That is emancipation. And that's really important. So you have it right there. Okay. And so you have right there. And in this case right here, that's another one in which minor consent is permissible. Number one, I would tell you something. 14 years of age and older. 14 years of age and older. And they are 14 years of age and older. They are already mature to understand what can be done with their body. Doesn't mean they're emancipated, but an agreement needs to exist between the mother and the child. They have to be agree in the same decision. If you are older than 14 years and any kind of decision you're gonna make, parents and child needs to be agreed. Nothing older than 14 years is still the parent making a decision, but the child needs to be agreed with the parent's decision. Is they are 14 years and older. Substance abuse. When they become emancipated in those examples you have right there, when they give you an example that the child says that they're suffering abuse to substances and they want to be detoxified, and the parent says, no, I don't want that to be published in a newspaper because I'm a famous, okay, a figure in the community. So I'm not gonna, okay, and I'm not gonna meet my child in a detoxification program. But the child say yes, and the parents say no. So what you will follow the child decision. So you don't want anyone, okay, with a substance abuse, with STD, okay, going, okay, outside to make, things that are not right, because at this time you're putting the public health in danger. You don't want that to happen. It's not good. It's not really good. Testing for HIV and AIDS, they might not say, I want to be tested for HIV because I believe I have unprotected contact. And the parents say no, the child say yes, you will follow what the child says because you know it's supposed to be HIV contact and can really, okay, hurts the public health. Okay, pregnancy, excluding abortions, psychiatric services in reference to, I want to be admitted in a psych unit because I'm bipolar. I'm looking, I'm having hallucination on this thing. Parents say no, you have to follow what the child says. Your child say yes, the child will be admitted. You don't want to kill, you don't want that child to kill someone outside. There's a reason. So in those situations, also minor consent is permissible. Understand? Tricky question. Tricky, but it's common. It's really important. This is kind of on associations that sometimes they ask you in your test, and when they ask you that, sometimes you are like little lost in what they're asking you, and yeah. So you need to know what it means, American Hospital Association, what they do. They issue Patient Bill of Rights, American Nursing Association, Mental Health System Act, and the Joint Commission. Sometimes they ask you, which of the following agency is in charge for this and that? And they're gonna give you the agency number. So you need to, the agency names, I'm sorry. So you need to know, okay? That's common too. And that's difficult because sometimes we don't know what they do. So we have to make sure, okay? Organ donation. Okay, really common, okay, organ donation. And the first thing I would say to you is that organ donation is not subscribed to any type of law. Okay, so what means that to you is that organ donation means that you need to have two witnesses when you're having your driver license and we ask you, are you organ donor? Yes or no? Yes. But what's the problem? The problem is, okay, that they're gonna give you the license for 10 years and we don't know, okay, is that probably, okay, can change in 10 years. What means that to you? That after the patient die, what is the first thing we do? Go to next king in the list. And that's really important. Okay, and what means, okay, the next king in the list is that before, even though the patient is an organ donor patient, before we call the organ donation agency, we need to call the first, okay, king in the list. Okay, and the first king in the list always will be the spouse. And even though you are an organ donor person, if the spouse says no, organ cannot be donated, even though you're an organ donor. And the reason is like that is because the only one that know what will be your last wishes, it will be your family. And in 10 years, you can change the religion, you can change to wherever thing, even though you're driver license and you're organ donor, okay, probably your wishes changed the last time. So we need to always ask a spouse. A spouse is not, okay, pretty much alive. Okay, we got pretty much an adult son and daughter. Okay, and adult son and daughter are not allowed. Okay, we're gonna go to adult, okay, brother and sister. They are not, okay, pretty much alive. We go to parents, and then parents are not alive. We go to legal guardian. No one is alive. Okay, we're gonna give it pretty much, okay, to the agency for donation. But we need to respect the skin in the list. And this is the most important about organ donation. Questions in your Nclex about organ donation is that some of the organs, including heart, lungs, and liver, okay, obtained from a person who was undergoing mechanical ventilation and just suffered a brain death. It cannot be for a cadaver. Those organs cannot be for a cadaver because if we ask you that, so it need that patients, okay, for heart, lung, and liver need to be, okay, in ICU with mechanical ventilation until the last minute in order for that organ to be donated for transplantation. All the organs, okay, pretty much like corneas, okay, things like that can be taken for several hours, okay, after death, but not heart, lungs, and liver. Okay, so we have to make sure that for organ donation, any the organs stand free of any kind of disease, condition, or infection. Okay, and that's, okay, pretty much and really important. And we always need to make sure, okay, about the religions. Okay, Roman Catholic Church, organ donation, transplant are acceptable. Islamic too. Don't make a mistake with Jehovah's Witness. Jehovah's Witness, they are acceptable organ transplant, but the organ need to be washed with a non-blood solution. With non-blood solution before transplantation. But they allow organ transplantation. And Orthodox Judaism, they also are, okay, approve organ donation. Okay, that's really important. You will know. That's in reference, okay, pretty much to management on, and right here, okay, in the charge planning. So do we have many questions about the charge teaching? Who is in charge to provide the charge teaching? Aaron, yes or no? Who's in
Yeah.
charge to provide, okay, and discharge reinforcement teaching RNs. Okay, no one else. Now, when you approve discharge orders without patient criteria, that would be abandonment. That would be abandonment. So we have to make sure that when they're talking to you in questions about the doctor, okay, give you a discharge order, you must make sure, okay, that question doesn't need to be questioned or challenged because, okay, that will be one of the possible answers. Okay, patient is in contact precaution and the doctor wants to give discharge to patient. No, you will say no. That patient doesn't have any criteria to be discharged. I'm sorry. Yes. And that's the kind of the answer that says question doctor orders or challenge, okay, doctor orders. And that's really important. Okay. Let's see right here. That's multidisciplinary team questions. Okay. So you will have questions about that too. Okay. Multidisciplinary team. What is the meaning of that to you? That is multiple people making a decision. So we have, okay, social worker, respiratory therapists, we have teachers, we have many people, okay, on working in that, okay, patient decision when actually can be discharged, for example. Okay, so, and we have to make sure, that's what we call interdisciplinary team. But you have questions about that too, okay? Now, consultation and refers, you have questions about that. Very common questions about on patients with after CVA. When the patient has a CVA and a stroke, and the patient suffering expressive aphasia, and the patient is not able, okay, to swallow food, so any type of fluids, what kind of refer that patient needs from the nurse? Speech therapy. That's very common. That's very common in your test. After the CVA, what is the most important refer? Okay, after the patient becomes stable, is speech therapy. That's really, okay, really important. So which means you must make sure, okay, you will, okay, provide an appropriate refer, okay, from that patient on following doctor orders, okay, but you always must make sure it's a patient we need to have a PT specialist or an occupational therapist, or that patient have a PT or an OT, okay, evaluation, because you will be the one to write the order. You will be the one. So you must make sure, okay, in reference to that. PT means, okay, on legs, OT means hands, okay? Sometimes they're gonna ask you, not so commonly, but they're gonna ask you, okay, pretty much, okay, about that too. So in reference to client reports, okay, and transfer, well, that is, okay, really important. And in reference, you always will report whatever happened to the patient in the last 24 hours. It's not whatever happened in your chief only. What's the problem right here? Assignment, delegation, and assignment. You cannot provide, you cannot say to the CNA, or you cannot say to the patient care technician, report this to the nurse, or give a chart, okay, or medications to anyone that is not an RN and is not in charge for that assignment when the patient is actually transferring from one nursing station to another. Is it going from, okay, floor 1 to floor 2? Nurses needs to go with the patient, okay, belongings, medication records, okay, and report to the another nurse wherever it happened during the shift before the patient will be changed, okay, from bed or floor. That's really important. That's really important. So you have questions about that too. And that's, okay, really important to know. So on, let's see what else. Delegation and assignment. Delegation is really important, okay? So, and sometimes, okay, you will have, there is a question of talking about settle that applying, okay, asking you about the 6 right of delegation. Okay, so you need to know which ones are. It's right task, right circumstances, right person, right direction, communication, right supervision, or feedback. Okay. We are talking about the right task, okay, pretty much talking about that wherever you will delegate to someone, it will be according to that, okay, nurse on a scope of practice. You cannot, okay, provide the right task to someone, okay, that it's, I mean, an activity that is out of the scope of practice of that professional license. And that's really important. Right circumstances mean that you actually have the right resources, okay, to delegate that activity, and cannot delegate something to you when you don't actually, okay, have the resources to do it. Doesn't make any sense. Right person, I'm talking about the clinical experience most of the time. So when those questions that which of the following on or to which of the following the patient needs to be delegated or whatever, you always will look for the person that have more experience, okay, working on that service, okay, because that care when you're gonna make a delegation and assignment. Right communication, okay, means when you actually set up to the delegate on listen, okay, that patient is in 202, second floor by the window, and then the name is Rosa Maria. Right supervision is when you actually fail to supervise. Okay, when, for example, they give you questions that the nurse, okay, give a sample to the UAP to take it to the lab, and the UAP, okay, right there, okay, leave the sample in the counter, and the result for the urine testing, okay, delayed, and the patient becomes worse and complicated. So you can be penalty and fail to supervise that sample, okay, was, okay, being taken to the lab. And that's really important to know. That's right, okay, I mean, fail for supervision. That's really important. So we need to know what the licensed people they do. Just always remember. Let me see if I have on a slide right here that is really important. Okay. On licensed assistant personnel, UAP, the reason that sometimes a lot of students fail this type of question because they don't understand what is the concept of the UAP. UAP is not only CNA. No. On licensed assistant personnel is including many disciplines together. It's including medical assistant, it's including on patient care technician, and it's including CNA. Now we ask you one question. CNAs can take blood sugar? Yes or no?
Yes.
No. No. PCTs can do it. Patient care technicians? Yes. Yes. Both of them are classified as a UAP. So when I'm talking about UAP, I cannot look only at that person as a CNA. It's not. Because the scope of practice of the CNA and the patient care technician is completely different. It's not the same. Even though they do similar tasks, it's more ample PCT than CNAs. CNA can take vital signs, but they cannot monitor blood sugar. But PCTs, they can do it. And both of them are classified as a UAP. So I'm saying UAP, okay, I'm talking about PCT, CNAs. So you must make sure. You must make sure. And sometimes that's the reason that some of the questions been answered wrong. Okay. They do any kind of grooming activity. Okay. They don't monitor or they don't assess range of motion, but they report lack of range of motion. They report it. Okay. They report it. They insert, okay, they place, okay, or they do condom catheter. They can do that too. They can take vital signs. They can do any kind of grooming. They can do transfer, as you know. They can even, okay, feed the patient. They can feed the patient through a peg-tube, but the answer needs to include under RN supervision. It's actually, okay, the statement is not including under RN supervision. You cannot choose that. Because UAP is what they use to alleviate nursing staff. Nursing tourism, yeah, nursing staff in charge. So which means that is that statement include on the RN supervision? Okay, we can also choose, okay, feed the patient on the RN supervision. That can be choose too, but it need to include that. It doesn't include it, you don't choose it. Okay, that's one of the sections. And but you have to make sure LPNs, they can do everything except IV meds, except initial teachings and discharge. But they can give intramuscular injections. They can give, okay, pretty much on subcutaneous. Okay, they can give on oral medications. They can apply medications topically. They can do urine catheterization, suctioning, dressing changes, all these things, but not IV. Anything related with IV, anything. And reduce the nurse, okay, can do all initial, all discharge, okay, and then care planning on intravenous medications, all the procedures, okay? Now, RNs can delegate to LPN, can delegate to UAP, can delegate to RN, but LPNs cannot delegate to RN. LPNs cannot delegate to RN. UAPs cannot delegate to RN. UAP cannot delegate to UAP, and LPN cannot delegate to ULPN. No, the only one can delegate to their own discipline or the same discipline. I'm sorry, it would be RNs, no one else, and that's really important. Okay, they're gonna ask a question, so you need to know. Okay, pretty much about the way we'll delegate pretty much. So now, time management, it's very important. Number one, when they ask you about highest priority, always look at the time. Which of the following patient is the highest priority? What is the most important? A patient that has a procedure done 4 hours ago and a patient that has a procedure done 48 hours ago. The patient that has a procedure done 4 hours ago. Okay? And when they usually using the statement days after something being done, that is not a priority. Most important priority would be whatever is done in the first 24 hours. Unless they says to you, the patient who has an myocardial infarction 2 days ago and now is going back with ventricular tachycardia. Well, that is a priority. And that's the reason, okay, you must make sure that we always, okay, read the statement completely, because sometimes the last 2 words of the statement is telling you the patient is going back to acute and it's becoming a priority right now. But we always look at the time. We always look at the time. It's really important, okay? And the time means that sometimes they're going to ask you to organize activities. The nurse is making a round, okay, of wound care, and they're going to, okay, ask you which of the following patient needs to be followed up first and organize, okay, that according to the highest priority. That is also time management, a home health nurse. So we need to know. And we always follow right there a priority. The time will be established, okay, according to the priority of the patient needs. And that's really, okay, really, really important. But always look at the time. It's really, that will help you, okay, to establish a lot of priorities. And always the first 24 hours is the most important time, okay? Priority, it's really important, okay? And so when we are on, give me 1 minute, let me see something right here. Okay, that's a kind of delegation, you see? Delegation and assignment, okay, or licensing assistant person, and you see everything they do, okay? On bathing, grooming, dressing, toileting, ambulating, feeding without swallowing process, okay, without aspiration precaution. It's really, really important. Applying heating aid, elastic stockings, ambulation, deep breathing, coughing, bed making, specimen collection, all these things, okay, they do. But look what it says right there. So they can do antiseptic drainage containers, all these things. So under RN supervision, because just remember, it's including PCT, CNAs, and medical assistant. You just be careful, okay? And you have right there what the LPNs do, okay? And it's really important. They on LPN monitor client feedings, they ongoing client teaching, okay? And all these things. And you have the RNs right here. Supervision and delegations that maintains accountability, all these things you already know. Okay, so now on when we are talking, okay, about pretty much on priority, let me go to these slides right here. That is really important to me. So we talk about all these things. Okay, This is, okay, what we always, okay, following prioritization, A way. So A, B, C, A on A way, breathing and circulation. Is you actually, okay, go to Maslow, you know that Maslow includes A way, includes breathing, and also circulation is talking about heart rate and reading. So you wanna go and establish priority, you can go straight down, okay, to the base of the pyramid, making sure you're always following the ABC. Now, we want to know what patients have stable, what patient is not. Okay, and the reason we go to a way always first is because the patient is not breathing. There is no point to do anything else. Okay, in reference to a way, which ones apply right there? People with O2 lower than 90, hypoxemic patients, but now have to be careful. This is how, okay, the NCLEX will evaluate to you your med search knowledge. Okay, they're not gonna ask you something straight, they're just gonna ask you, okay, pretty much about which of the following patient is the highest priority. So you need to know. Okay, O2 lower than 90. Now let me ask you something. An O2 lower than 90 in COPD patient is normal?
Yes.
Okay, from 86 to 90, it's normal. Lower than 86, okay, it's when it becoming hypoxemic. Any people with APG, blood gas imbalances, respiratory condition like COPD, asthma, pneumonia, exacerbation. That will be pretty much, okay, an airway management. On congestive heart failure, exacerbation. Because chronic conditions, okay, are not a priority. Are not a priority unless the statement says to you that is exacerbating, will give you sign and symptom of exacerbation, because you know what is expected in patients with chronic conditions and it's not classified as a priority. Okay, patient with an 300 or blood sugar and regular insulin was given and it's at risk for a hypoglycemia, is that a priority for you? Yes or no?
Professor, could you repeat that, please?
A patient with 300 of blood sugar and the nurse administers regular insulin intravenously and is at risk for hypoglycemia, is that patient needs the highest priority?
No.
No, because whoever you give regular insulin is expected to suffer hypoglycemia. What do you want me to choose that? What do you want me to choose that? No. No. And actually, we're going to give you 4 choices, 4 answers. And letter A says diabetes mellitus, and another one congestive heart failure, and letter C hypertension. But the 4 answer, it's not diagnosed. It's telling you the patient arrived with shortness of breath, okay, with headaches, with malaise, with weakness, but I don't give you a diagnosis in that answer. That patient has a priority because I may still need to find out as a nurse what it is. There is nothing expected on that guy because I don't know what's the condition. I need to make sure. When actually they give you 4 answers and 4 of them are diagnosed, I will look for the one that is getting an exacerbation as a chronic condition. So I need to know the signs and symptoms. Okay, it's many conditions, and this is how they will evaluate to you on physiological integrity. That is another category, subcategory. So second would be breathing. What type of breathing? What type of breathing? They're not gonna mention to you, okay, and to be honest, pretty much the name of the breathing, they will describe it. They will describe it to you, and that's the reason. We need to know, okay, how do we describe the type of breathing? That's really important. And when actually they're talking about tachypnea, it's an increase in respiratory rate. Bradypnea is a decrease in respiratory rate. It's 2 opposite breathings right there. And apnea is accent of breathing. Very common, okay, the chain stocks breathing. when actually, okay, increase and decrease in respiration with periods of apnea, that will be, okay, pretty much on, that will be a priority when the patient, look at this, okay, chain stocks breathing, okay, that would be a priority when the patient is at the hospital. When you have a disaster, when you are in a disaster situation and the patient is outside the hospital and you have chain stop breathing, that you know that patient is using accessory muscles to breathe, that patient is dying. And it's not my priority because I'm in a disaster situation right now. I'm outside the hospital and not inside. When actually I'm inside the hospital, that type of breathing requires first priority, but not outside. Different scenario. Okay? On Kussmaul respiration, okay, very common in people with diabetic ketoacidosis, okay, and it's, okay, pretty much when the patient becomes salt, okay, tachypnea and also hypopnea too. And so we need to know the type of breathing because they will describe it to you. They will describe it. They're going to mention the name most of the time. They will say shallow and rapid. They will mention, okay, increase the respiratory rate. That's what they do. So we need to identify which one is. Circulation, decrease of cardiac output. Anyone have decrease of cardiac output, we have two things right there: congestive heart failure, cardiogenic shock. That will need to have an immediate, okay, and priority. Fractures, any kind of fractures, including long bones, there will be very at risk, okay, for fat embolisms, okay, which is really important, okay. And also when they are with dressings, okay, tight dressings, they can be a risk for compartment syndrome, okay. Dehydrations, cardiac, any kind of cardiac arrhythmias, any kind of irregular heart rate need to have, okay, first priority too. So we need to know how to establish ABC. Not in all the questions priority, okay, will be ready with ABC. When actually on the patient is having problem for elimination like autonomic dysplexia, that will be pretty much a priority. When it's not related, okay, with organic situation and it's more safety in which a patient is at risk for, and like protect the patient from injury. But the scenario we already give you, in what priority is the patient located right now? It gets to know. Is it walking with crutches? Why do you want me to choose ABC? What the hell? I mean, I'm not talking about right here about way breathing and circulation. I'm just talking about how do you can operate, okay, on a walker, how you can operate, okay, pretty much, okay, on a crutch or crutches. Why do you want to choose a way? No, makes sense. My priority right there would be about muscle strength. If you don't have muscle strength or muscle tone, you won't be able to operate the crutches properly. So I need to assess the patient range of motion, muscle strength before they use, okay, the device to minimize safety issues. Completely different. And we ask you more about, physiological integrity or physiological needs, and safety, okay, that other, okay, steps, you have the other steps right there on Maslow. Now, the question is not related with safety. I'm not talking about crutches, walker, risk for falls anymore. I'm not talking about patients in immediate situations or emergent or urgent situations, okay, which requires implement ABC. Now I'm talking about nursing process. How do I know? My priority question is talking about nursing process. The nurse is assessing. The nurse is planning. The nurse is evaluating. The nurse is implementing. Forget about ABC anymore. Forget about, okay, Maslow. We are talking right now about a question that is related with nursing process. My priorities will be related with nursing process, and I need to go back and remember the steps of the nursing process. And always the question in your Nclex about nursing process, it will be about assessment, nursing diagnosis, and implementation. Okay? Most commonly, when they mention to you, the nurse is assessing, and they're talking about assessment, as the first step of your nursing process, I will look to my answers. And I will choose any kind of answer that is including any of these words right here. Identify, determine, observe, gather, and collect. When actually any of these answers is including any of those words, that is my answer. Because assessment interventions use this kind of words following Bloom taxonomy. And there is no other way around. They will be able to formulate an assessment intervention if they don't use some of those words, which means that other times when they're saying to you, the nurse is assessing, look for any of those words in one of your answer, and that will be your answer. Good strategy for you, because that is very common in your Nclex. So you need to know. Nursing diagnosis question, anything that is risk, at least the 4 answers that give you mention risk for something is a priority. Is I have 4 answers talking about risk, okay, for something. Letter A, risk for this. Letter B, risk for that. Letter C, risk for this. Letter D, risk for that. Well, I need to implement ABC in those 4 risks. But it's actually, okay, I have risk between the 4 answers. And there is other answers I'm not including risk for something. That risk is not my priority. I cannot choose impair for gas and balance. Okay, I cannot give a priority a risk for fall than impair for gas imbalance or gas exchange. No, risk is not happening right now. Imbalance, okay, or impair for gas exchange, it's happening right now. So which means, so I need to know. Implementation, it's when they say to you, then it's implementing. When they mention to you, then it is implementing, look for words that indicate that you're using your hands to do something, like reposition, like turn, administer. Okay, it's really important. Provide, change, yeah. And then when you see any of those words between your answers, that's your answer when they're asking you and they're just implementing. That's really important because they will ask you. In assessment and missing monitor, okay, because monitor is part also of your assessment keywords. That is a very good strategy, so you will know. Okay. And another priority would be about health promotion. Okay. And when we're talking about health promotion, we have first level, second level, and third level health promotion. Okay. And first level always will be teaching, and second level always will be screening, and third level always will be management. When they give you the question, the nurse is primarily doing this, doing that, I will look for a statement that is related with teaching. Or I will look at a statement that is related with vaccination. Because vaccination is a way of teaching. Okay? When actually saying the nurse secondarily, okay, that means a screening, lab test, diagnostic testing. I will actually say the nurse tertiarily, it's management. I'm already know the condition. As a nurse, I need to know, okay, what to do in order to control yourself. This is the way it is. Because health promotion, also they're going to ask you about priority according to the first, second, and third level, but they always are going to clarify to you what level they're using in the question when they're asking you something. Okay. And that's really important. So this is a type of priority that I'm always, okay, using when I'm teaching you about priority. Now, guys, don't use something that is not, don't use a statement that is not giving you accurate and concise information. It's really important. Nclex, they don't want you to do that. It's Centennial, which is the following patient is the highest priority. I'm actually giving you 2 months child with diarrhea. Now we ask you something. A 2-month child with diarrhea, 2 months old child with diarrhea, that patient needs the highest priority. Two months old with diarrhea episodes. Is that a priority for you?
It's important, but I think it's not acute, right? The 2 months.
It's not accurate, and the reason it's not accurate is because I'm not specifying how many episodes of diarrhea.
Ah, okay.
Got it.
I'm driving
This
on
is
my
this
bed.
is yeah, and that is one of the most common trick in your Nclex when they give you priorities, you know. Remember, we are using your word, we're using this, we're using that, and that is helping us a lot. A lot, a lot, a lot, a lot. But Nclex is not linked with any of these reviews. They have their own language. It will help you 100%. But when you get there, you will see many things different. So be prepared because it's the way it is. And that's the reason. They just wanted to choose something that is giving you everything that you need to know. 2 months old child with 3 episodes of diarrhea in the last 4 hours. Well, now we're talking. No. That's the one. But I cannot assume information that is not actually including the statement. Understand? That's really important. So I'll give you many tips for priority right now. So and I give you these 4 classifications right there. When they give you someone with recent change in mental status, alteration of consciousness, alteration of the vital signs, and acute pain, any patient following one of those 4, it's classified as an uncontrolled, unstable patient and requires always the highest priority. It's not so difficult. It's not so difficult. Okay, that's so really important. Okay, and you have an example COPD patient, a COPD patient with dyspnea on exertion. That is expected patient with COPD. What do you want to choose? Okay, that's the first priority. Only because you see a word dyspnea, it's normal. All patients with COPD are dyspneic. So what's the problem? You know, so we have to read carefully. We have to read carefully. Okay. And that's okay, really important. So you need to ask yourself, if the patient is continuing deteriorating, ask yourself if the patient requires immediate treatment, doubt to yourself, okay, on any kind of long-term consequences of disability, if we don't do something immediately. That's really important. So that's a tip for priority, so you need to know. That's the next thing on the list. I've been talking to you, okay, for organ donation. That's really important. So yeah. The first one is a spouse, adult son and water, parent, adult brother and sister, and legal guardian. Okay? Sometimes they ask you, so you need to know. That's safety. We're going to include, okay, safety, because when I go to safety and infection control, okay, pretty much in the next PowerPoint, not in this one. So we're going to talk about that. It is really important. Environmental safety. Now, the only thing I was missing right here, it was in reference, okay, on 2 disasters in priority. When the patient, okay, it's on in a disaster, and listen, it's really important because I'm putting my camera on just as you want to put your camera on and putting mine on. So in referring to disaster, it's really important to know, okay, to you to know, guys, this, it's not the same. Okay, when we have internal disaster, okay, that means that disaster is happening at the hospital. Just remember, when it's happening at the hospital, okay, the most critical patient, always we have the first priority. But look at the question in your Nclex. Look at the question, how much tricky it can be for you. A triage nurse go to the closest emergency room and say that it's there is a massive accident and they are arriving, okay, to the closest ER. They're arriving to the closest ER. So as soon as the patient arrives to the parking space or parking lot of the hospital, you always will give the first priority to the most critical, because you have right there all team to help you, all team, all resources, everything you need, even though that in the parking lot of the hospital, to provide the first priority to the most critical patient. But when that patient is outside of the hospital, outside, it's not getting to the parking space, not even close to the hospital, it's still outside, less critical patient needs to have the first priority. Okay? Whoever has a black car, you know that patient is dying. So you know, don't give first priority never and ever to a black car, because you know that patient is dying. Okay, very much. And you always are gonna give the first priority, I mean, to the less critical patient. That's really important. Massive disaster, it's classified when it's an accident or something happened in which more than 50 and 100 life is compromised. It's not an accident between a car and a motorcycle, because also the Nclex do that and it's really tricky. Okay, massive accident need to involve at least 50 and 100, okay, life in that accident in order to be classified as a, you know, a massive disaster. So don't be confused. Okay, make sure. Now, any question about everything we just discussed right here in the review? Anything you're gonna ask me? We cover our management of care. I don't think I'm missing anything right here. So next Friday, we're gonna go, okay, about infection control. So we're gonna go over a couple of questions right now. Okay, so that can really like reinforce, okay, most of the subject we discussed together. Okay, but how do you feel? I mean, do you think that many of the subjects being clarified to you? It was good for you?
Yes,
Yes,
Professor.
Profe. Thank you.
Yeah. Because, you know, infection control, okay, next week we're going to go over many things, because there is many things that you need to know right now, okay, that are included in the test. And let me tell you something, this is the highest, the most common and the strongest category in your exam. Management of care and infection control. Most with the COVID. If you don't know, I will tell you right now, Nclex is changing according to the community needs, okay? You're going now to US1 probably to make the test. And you live in Dade County, in Florida, Miami, Florida, right here. That's the state, Florida. And you know, with the pandemic, we're good. So they always are giving you as much questions they can about most common situation the community in the state you live in at it's facing on that time or right now. That's really important. They do that analysis. So they always do. So expect that there will be many questions about management of care and many questions on infection control in your test. Many of them. So next we're gonna talk about infection control. So we're gonna go over on all kind of on isolation precautions, diseases, pictures, how you can identify the condition, microorganisms, because in infection control, not always they're gonna give you the name of the condition. Now what the Nclex is doing, that they're gonna give you the name of the microorganism is on, it's triggering pretty much on who's in charge for transmitting that disease. And you need to know according to the microorganism what kind of isolation the patient's okay needs to be in. That's really important. So we're gonna go over that too. So now let's answer. Okay, some of the questions, I'm gonna share my screen. So we're gonna go, okay, over on some of them. At least for on 30 more minutes. And you have it right there. Okay, that's on the first question we're gonna go over. And it says that on A client with leukemia has been considered for a bone marrow transplant. The healthcare team is discussing the risks and benefits of this treatment and other possible treatments with the goal of inflicting the least possible harm on the client. Which principle of healthcare ethics is the team practicing?
D.
Is everyone agree with D?
D, yes.
Yes.
Yeah, do no
That's
harm.
your answer. Okay, it's letter D. Really good. Let's go to next. The registered nurse has accepted their new positions as case manager in a hospital. Which of the following responsibility are part of the nurse new role? Select all that apply. It's a good one. That's a good one.
Doctor, profe, the first one, she can evaluate, but she can update the plan of care as needed. She can do that. Change it, update it.
What do you think? Who's in charge to do care plan? The only ones can do care plan with BRNs, no one else. Yes, you can update it.
Okay. No, I thought that you
Yes.
needed a doctor's order to update it.
No. Care plan is not related with doctors. Care plan is related only with nurses. And
No,
as
yeah,
soon
I
as
know,
the
but
patient, as soon as the patient is improving, you update the care plan.
okay.
Doctor orders something, okay, but you update the care plan, nothing.
Okay.
It's a document that is done by RNs and is signed by RNs. Doctors never sign care plan.
Okay.
Everything except B.
Everyone agree?
Professor,
Agree.
I think C and D.
C and D and also A apply because you can evaluate and update care plan as needed. And you need to establish safe and cost-effective plan of care with the client. It's right, all of them except B. Because case management means try to provide to a patient whatever type of or try to cover whatever need they need to the lowest cost. So E, it's good. You coordinate consultation and referral to facilitate discharge, you do that. You're assessing the client needs for home supplies and equipment, you do that too, because that is management. Okay? And you also evaluate an update care plan, but you cannot prescribe treatments. That is only ND. Okay? So it's right. So it's A, C, D, and E. Let's go to next. And it's preparing, okay, client for a bronchoscopy and knows the client is wearing a gold necklace. What should the nurse, okay, do to safeguard the client necklace?
B.
C.
Okay, let's go and ask the client where the necklace is gold. Is that important for you? No.
No.
So that answer, garbage. Ask the client for permission to lock the necklace in the hospital safe. What about that one?
Yes. Yes, sounds good.
Yeah, because you cannot leave it at the top of the door, the bedside table. If the
Because you have to
necklace,
lock it.
okay,
Or it's
something
locked.
happened, is missing, you will see a problem. You don't want that to happen. Ask the client to sign a release to free the hospital responsibility if the necklace is damaged or lost during the procedure. That one is important, but I will say that the most important, okay, for the patient is to keep it safe. And remember, I talked to you about the safe box that we have at the hospital in which is we place the patient belongings. That's what we always do. Or we ask any family member to take this belonging away from the hospital if the patient is agree or give you the consent. Okay, it's let it be your answer. Okay, we always have to put in a hospital safe because most of the patients are gonna have a procedure. How most anxious the patient will be thinking that something is gonna happen. Okay, with the Nclex. Okay, because I'm not taking care of the Nclex because we have a procedure. So that impair the outcome of the procedure. So we always try to keep the patient as most relaxed. Okay, we can. And according to the policy, we always have to keep it in hospital safe. Now, unless preparing a client to go to the radiology department for a check X-ray and know the client is wearing a religious medal on a chain around the neck. The client or Catholic expresses a concern about removing the medal. What is the most appropriate action for the nurse to take?
A.
Asking the
Okay.
client to remove until the X-rays has been completed.
Look what it says right there. Okay, a wearing of religious medal on the chain around the neck, and the client is Catholic expresses a concern about removing the medal.
Yeah, but you can tell them, hey, when you get the X-rays, you put it back.
Yeah, but you cannot add against the patient values and religious belief.
Professor, I
Even
think
though,
Okay, okay.
even though to remove it for 5-10 minutes, but there is a concern because they will believe
Okay.
something is going to happen to them.
Okay.
We talk about that in the PowerPoint. Remember about on waiting on the waiting bands when you're gonna get married or something, and you have that band and you want to remove it, or you have a scapula, you want to remove it. What do we do before surgery?
B.
Your
Yeah.
assistant,
That
the
case
B
B.
one. Your assistant.
You see, you
But
assist
they'll
the
have it
client
on.
with putting the meter and change the waistband of the client's pajama buttons. That's what we do. We just try to hide it, making sure it's not going to impair X-ray. Nothing is going to happen. But is that concern about to remove it? We cannot act against patients' autonomy, values, and belief. They don't want to. And the same for surgery. We take tape and we tape it. But then we need to ask in a consent that we are not responsible wherever it's going to happen to those on values after we remove the tape. We are not responsible. We're going to keep it because we want to keep it, but we're not responsible for what is going to happen after we remove the tape from that on values on object. And that's really important. Okay. So you have it right there. A nurse and extended care facilities instructing a class or assisted person about client use assisted device during ambulation. Which of the following instruction should the nurse give to APs about the client use of a cane? Safety.
A as in apple?
A as an apple, because that's what we do. We move the cane first 30.5 centimeters, 12 inches. Then we move, okay, the weak leg, and then we move the good leg after. And we always hold the cane in the stronger side. And we always keep it flexible with the elbow at 30 degrees. Because in other Nclex, we ask about that. We ask about that. How does the patient cover with a cane? So, really good. It's letter A. A physician writes a medication prescription in a client's record while transcribing the prescription. The nurse knows the prescribed dose is 3 times higher than the recommended dose. The nurse calls the physician who states that this is the dose that the client take at home and this is acceptable for this client condition. What is the appropriate action for the nurse to take?
You verify the dose, you verify the prescribed. D as a dog.
Verifying the
Contact
prescribed dose
them.
with the client before administering the medication. Why? That is included already in the question. And don't choose answer.
Contacting
that
the
is already covered.
supervisor.
No, yeah,
The supervisor.
that one.
But,
Because
but
you already
normally,
verified that with the doctor, and he says that, well, that's what I'm prescribing, and that's the way it is. You
but
cannot give it if you don't feel safe.
normally,
Claro, if you don't
professor,
feel
I was gonna take it. I was gonna take if they put contacted with the pharmacist.
It's that between your answers.
Yeah, if they put the pharmacist, I was gonna take a pharmacist because it may be they can change the dose, but if you see the patient was taking like 1 or 2 milligram, and if you know
No,
it's not
but
safe for the
just
patient,
okay. Just tell me what is the outcome contacting pharmacy. What the pharmacy will tell you.
the pharmacy, if the medication is a wrong dose, they send the wrong dose. You need to contact the pharmacy. Maybe that was an error.
Yeah, but it doesn't say that the pharmacy make a mistake. What are you assuming something is not in your question? It says the
You're right.
physician write medication prescription in a client's record while transcribing the prescription. It's not a pharmacy, the one that is making the mistake right
Yeah,
here.
the doctor was the one
Is
who brought
the
it.
doctor, and that's the reason I'm always saying go and read the subject of the question carefully. Is the physician the one that is making a mistake, not the pharmacy? Okay, and you are not agree with it, with what the doctor is prescribing. For that reason, we challenge the doctor orders or we contact the supervisor. Now, since actually we identify in the scenario that the pharmacist is making a mistake, we have to contact the pharmacy. But I'm not mentioning pharmacy right here. Got it?
Got it. Thank you.
Yeah. We need to read carefully. No, but it's okay. It's okay. But this is what it is. Now they can put you between the answers contact pharmacy, but if you choose that one, it's wrong. Because pharmacists don't make a mistake. They will say, hey, what are you talking to me? I'm not sending you any wrong dose to you. So it's the physician mistake. Yeah, so you have it right there. Got it? So we have to be careful. Now let's go to next. And it's monitoring a client with a chest tube knows that there is no titling of fluid in the water CR chamber. After further assessment, the nurse suspects that the client lung has responded and notified the physician. The physician verifies with the use of the X-ray and the lung has responded. Then calls the nurse and to ask the chest tube being removed. The nurse should first.
See?
I've never seen that question.
Are you weak in chest tube? You feel weak in chest tube?
Yeah. When you asked
Okay.
me the other day about which questions that I couldn't be on that review of the EKG, I was going on to tell you also about the chest too, but I forgot to tell you.
Okay, we're gonna cover that next Friday, okay? I'm gonna put a picture to you about chest tube. I'm gonna explain to you how the chambers are connected. I'm gonna explain everything to you about chest tube.
Thank you.
Don't worry. Professor. Okay, now it's letter C, because the standard of care, what it says is that we assist the ND removing the chest tube, but we cannot remove the chest tube by ourselves.
I
That
didn't know
is not
that.
good. Yeah, do we ask the patient, hey, take a deep breathing? The doctor remove the chest tube, and then after that, when it's removed, we need to place right there a seal dressing. Okay, a seal dressing means, seal means sellado. Seal dressing that is pretty much closing and sealing the four corners of the insertion site, making sure that any air molecules get into the pleura. Got it? And then we send the patient back home. Okay, but we don't remove chest tube at all. Okay, Good. Really good. I know it's a difficult subject, but I like it. So we explained to you that last week. And it's called a physician to report that the client with congestive heart failure is exhibiting dyspnea and worsening of wheezing. The physician who is in hurry because of the situation in the emergency department give the nurse telephone prescription for furosemide Lasix, but does not specify the route of administration. What is appropriate action on the part of the nurse?
Calling the physician again, I imagine.
Perfect. And
A.
clarify the prescription. Really good. Really
A.
good. A nurse assisting a physician in assessing a hospitalized client. During the assessment, the physician is paid to report to the recovery room. The physician leaves the client bedside after giving the nurse verbal prescription to change the solution and rate the intravenous fluid being administered. What is the appropriate nursing action in this situation?
It's B, doing what the doctor said, taking the verbal order. B, changing the solution and rate per the physician verbal prescription. Dice ahí. Verbal prescription are not accepted, doctor, profe.
Verbal prescription are accepted. Changing the solution and rate of they be per the physician verbal prescription. But look what it says right there. The physician leaves the clients on bedside after giving the nurse verbal prescription to change the solution and rate of the intravenous IV fluid being administered. What is appropriate nursing action? Now,
He's giving them.
now verbal prescription is giving over the phone.
Oh.
If the doctor is actually on the floor, he needs to write it by himself.
Oh, okay.
So C is the answer.
C is the answer.
Good questions.
Okay.
You see,
Good question.
this is what it is. Now, if I'm actually calling you, it's a verbal one. It's what we call telephone verbal order, you know. But if it's on the floor, hey, write it by yourself, because that is so confusing to me. So sorry, it's not like take a write an order right there for the patient for the wound care or refer to something or just an antibiotic. It's complicated, that order.
It's something more complicated, yeah.
It's
Life depends on
complicated.
it.
So
Yeah.
the level of the order, it's complicated. So you better write by yourself, because you cannot make a mistake. And actually, the order is not clear. So
Question,
it?
Professor. Question.
Yes.
So in which situation would we choose D?
Telling physician that the prescription will not be implemented until it's documented in the client's record. And
Documented there means like order in the record,
yeah,
right?
documented means that it's not very much prescribed. Documented means that he will write in the progress notes that that medication was prescribed, but it's not actually prescribed. Got it what I'm saying? Because when we're talking about documentation, we are talking about different section of the patient record. Got it?
Got it. Yes.
Yes.
Thank
Okay.
That's
good.
why.
Yeah. We're right there. Let's go to next. And in this getting for the client has methicillin resistant Staphylococcus aureus MRSA in abdominal wound. The nurse enters the room and check the client pulse. Which is the following action to the nurse take?
Clean gloves.
C, contact.
D.
See? See as in cat?
on other getting emergency on now. Now, I will tell you something. Abdominal one. What means that to you?
Splash.
Okay. Abdominal one requires an steady procedure or clean procedure.
Oh.
A clean procedure.
It's
It's a,
Good.
it's an
proper, but it
abdominal
says to
one.
clean, to check the pulse.
Uh-huh. Enter to the client's room and the client, okay, and you the nurse enters the room to check the client pulse, which is the following action, okay, to the nurse take.
Yeah, it's just the pulse. I think the one thing is the distractor.
So what do you choose? A steady glove or clean glove?
To the pulse. Clean gloves.
Clean glove,
In gloves.
no steady one. You're right. Okay, because it's only the pulse. It's actually he would do something with the one, it will be a steady, but it's saying only the pulse. Clean glove. What kind of precaution is that one?
Contact.
Perfect. Out of time when you
And
see the
standard.
word resistant, out of time when you see the word resistant is always contact precaution.
The others one too, profe. The Versa,
Yeah.
the other one.
Yeah.
Okay.
Yeah, out of time when you see the word resistant is always contact. For any kind of condition, okay? A client is scheduled for a surgery, tells the nurse that the sign informed consent for the surgical procedure, but was never told about the risk of the surgery. The nurse said as the client advocate by.
B as in boy.
Perfect. Calling the surgeon.
Calling the surgeon.
Calling the surgeon. Perfect. Let's go to next. And they discovered that another nurse has administered an email to the client, even thought the client told the nurse that did not want one. The most appropriate action for the nurse to.
Here's when you don't know what to do, because I don't know if you know if you you report the incident to the nursing supervisor or you confront the nurse as you were explaining earlier.
Well, look what it says. The nurse discovered that another nurse has administered. Is in past or is in present?
No, it's in past. I know.
So
Yeah.
you don't confront it because confront means at the present time.
Oh, okay.
I know.
Yeah.
You see, you always have to read carefully.
You don't go to the nurse and talk to her. No?
I mean, you can confront, okay, actually the nurse is you, okay, see if you are in the middle of the situation, but was already administered.
So you have to contact the nursing supervisor. Report the incident to the nursing supervisor.
You have to contact the nursing supervisor. You have to.
Wow.
Yeah, you have to. You have to report the incident because I mean and it's something that's a bodily situation. Got it? And it's a bodily situation, so you have to contact the supervisor, okay? Got it?
Yeah.
Understand?
Yeah, Prof.
Okay. Go to the next question. A nurse called physician to question a prescription written for a higher than normal dose of morphine sulfate. The physician changed the prescription to a dosage within the normal range, and the nurse documents that the new telephone prescription in accordance with the agency guidelines in the client's record. Which other statement does the nurse document in the nursing notes? That's documentation, you see?
A as in apple.
A as
The
an
physician
apple.
was called to clarify the prescription.
The
for
prescription
morphine
for morphine sulfate. Really good. Really good. The nurse had just finished doing irrigation for the client who requires contact precaution, which is the following pieces personal protective equipment PPE should the nurse remove first. Easy.
The gloves.
Easy. Really good. A charge nurse on the 11 p.m. until 7 a.m. shift is gathering the nursing staff together to listen to the 3 to 11 p.m. inter-shift report. The charge nurse knows that the staff member has an odor of alcohol in her breath, slurred speech, and a steady gait, and suspect alcohol intoxication. The charge nurse will most appropriately
Send the staff member home.
send the staff member back home. Really good.
Profe, pero besides that, they don't do they don't enforce anything to the nurse. Doesn't have any more problems.
Suspect alcohol intoxication until you don't have, okay, a blood level, you cannot do anything.
That's why my question. You send that person home, but you don't do anything before. You don't report it. You don't do a test.
You
don't do anything?
cannot, 11 p.m., 7 a.m. It's not time to do a lab test. Look at the time.
Well,
But on, you know, that's then,
overthinking. That's overthinking.
yeah,
Como
you
dice
can,
Dr.
you
Baye.
can,
That's overthinking.
you're not gonna ask the staff member how much alcohol she has consumed because,
No,
okay, doesn't
no.
make any sense. Tell the staff member that she's not allowed to administer, okay, medications.
No, she cannot work at all. I know.
Exactly, and the
But
staff member
so that person
to
goes
rest in the
free.
nurse lounge until the first alcohol went off. That answer is not included. That would be included. I would test it, but it's not between your answers. You know.
No. I'm asking you in the normal life. You
No,
send that
you
nurse
need
home.
to do a testing immediately. It depends on the settings you're working at. Is that at the hospital? Okay, will be tested immediately because we have labs 24/7.
Mhm,
But it's in
mhm,
a rehab center or something, we cannot do
mhm.
anything, okay, until the next following day.
Okay.
It depends on the setting because you will send them back home, but you cannot, okay, test the nurse if you don't have, okay, how to do a blood test available. And you cannot,
Okay.
even though you feel the alcohol on smell, we need to have an objective finding before we accuse someone about something. That's the law. Even sounds illogical to you. Anything is illogical here, but that's the way it is.
Okay.
Got it what I'm saying? And you have,
Yeah,
and that's curious. Let me tell you something. Do you have many questions about that probably I don't talk in management of care, but I will tell you right now that do we have many questions in which is, and that's referring to defamation. I forgot to mention that example to you, that on the nurse, on a CNA just go to the register nurse and accuse another nurse about abuse. We cannot go and take interventions immediately until we don't open an investigation first. In the real life, the answer for whatever statement you have from someone accusing another person about something, the first interventions will be open an investigation to collect facts. We cannot implement an intervention against someone until we don't have objective information, because we don't know what is the intention of the patient that is reporting something, but we're not actually seeing. Got it what I'm saying?
Yeah, Prof.
You can tell me that you see the charters abusing from drugs. We need to open an investigation first. Got it?
Yes.
Yeah, that's the way it is.
Yes, thank you.
A client asks the nurse about the procedure for becoming an organ donor. The nurse tells the client.
D as in David. Let the physician know about the request so that it may be that it may be documented in the client's record.
Those things always needs a informed consent sign. That need to be signed.
Yeah, and the one that
Hey.
signs is the patient, not the physician.
Yeah, that's always need to be signed by the patient.
Yeah.
In writing is A.
Exactly. It is. It is A.
Ah, the anatomical gifts.
Must be
Okay.
made in written and signed by the client.
Yeah, it's true.
The other one that signed the consent, no one else. Yeah.
You have to read carefully. Take your time.
A nurse enters the client room and administers a medication that has been prescribed by the physician. The client asks the nurse about the medication. Which response by the nurse is appropriate?
A, apple, because D is too much. It's not like in layman terms, I think.
But on which one is giving you more information?
It's the most complete.
Oh no, yeah, for sure. But I thought that the patient wouldn't understand about the electrolyte levels. Yeah, me overthinking. So I think that A was better, easier to the patient. I don't know, just babbling.
Always, okay, choose for the one that is, I'll give you more information. For that, okay, the question need to specify to you that the patient have a low level of comprehension or the patient have a low level of readiness to learn. And the question is not specifying that right there. Okay, don't assume anything because you can have patient with on high level comprehension and probably we understand whatever you're saying. Now you have another one that probably not, but the question is not saying to you that patient have a problem with the language or understanding medical meanings.
No,
So,
it's true that you have to inform
so
the name of the medication.
yeah, you cannot assume
Oh,
something's not
hey,
happening.
I'm putting this, this, that. Yeah, it's
Yeah,
true.
dog, you cannot do that. What about if the patient was a doctor before? You never know. So that kind of okay.
Yeah.
That's it. That's the deal. So you cannot assume something's not happening. Okay.
Yeah,
Good.
it's true.
Yeah.
Sorry.
No, little by little. A client with cancer is transported to the radiology department for a bone scan to determine whether the cancer has metastasized to bone. While the client is in the radiology department, the client wife arrived for a visit and asked what test is being performed on the client. What to the nurse? Okay, tell the wife.
She can sell.
B?
Today I'm stuck. A bone scan is being performed.
Said,
It's B.
You cannot tell the wife.
okay, let me read it.
The nurse cannot tell to the wife a bone scan is being performed, prof.
Hold on.
Just that.
The client is in the radiology department. The client wants to arrive for a visit and ask the test. What is the test is being performed on the client? What to the nurse? Okay, to the wife.
What test is being performed?
She
She
will
just
have
want to know the
also
test.
the prescriber test with the client. Wow. A bone scan, okay, it's being performed. Yeah, but again, a client with cancer is transported to the radiology department for a bone scan to determine whether the cancer has metastasized to the bone. While the client is in a radiology department, the client wife arrived. Now, I cannot say a bone scan is being performed because this question is not specifying. Is the clients arrive for the visit and ask what the test is being performed on the client. So what do you want to, repeat what the wife already know?
The wife doesn't know.
No, the wife says, well, the client is in the radiology department. The client wife arrived for the visit and asked
Arrived.
what the test is being performed on the client.
No, no, profe dice, and ask what test is being performed. She want to
What
know
test is
what
being
type of test.
performed? Okay, on the client. Oh, I got it now. A bone
She doesn't
scan
know.
is being performed to the client. She will have to discuss the prescribed test with the client.
I agree with that.
The radiology department is not clear as to which test is prescribed. Okay, she can read. Okay, the client medical records and how the physician prescribe it.
So in that case, B is the right answer.
I would say yes. I would say yes because on the reason is that is the patient decides to go for a bone scans without telling the wife because it's alert and orientation string. You know, he was agreeing with that decision. So I think that the wife is the one that had to talk to the client, okay, and about the reason the procedure being done. So we cannot say a bone scan is being performed. No, because that, okay, she can assume that we do it without patient consent. So I think that she was the one that has to discuss with the prescriber test with the client because he was agreeing to doing it. And as a reason, okay, he doesn't notify the wife. As soon as the patient is transported to the radiology department for the bone scan to determine whether the cancer has metastasized to the bone, it's because the patient is accepting, okay, that the test will be done. So she's the one that needs, okay, to talk to the client about why he doesn't notify the wife before doing it. If the patient is an alert and orientation to patient, he doesn't need to notify to no one about a test that will be performed. That's their own decision. Got it what I'm saying?
Yeah,
Now I cannot say a bone scan is to be performed to
Yeah.
the wife because it will look like that I take a decision by the patient. And I'm not. Understand?
yeah, yeah.
Yeah, Professor.
Yeah, it sounds like well, I did it because I did it because I'm the nurse and I want I don't know. It just to like, well, now discuss that with your husband because he was agreeing to doing it. Now that he needs to call you or not, that's not my fault. It's not mentioning right there in the question the patient is mentally ill, anything like that. That the wife is a proxy. Now, if the wife is a proxy and the patient is mental ill, now we have to call the wife. Now it would be a problem. But the question is not mentioning anything like that, so the patient can decide on whether or not that test can be done. Okay? You see how much tricky can be?
Super
Yeah,
tricky.
yeah, I know. Let's go to the last one. This is planning care for a client who requires a month precaution to the following action to the new stake. I think that is really easy for you to answer that question.
B.
B.
B. Let's go to the last one. This one is good. And this is planning care for a client who requires okay. A physician informs a nurse that the husband or unconscious client with terminal cancer will not grant permission for the Not Resuscitate order. The physician tells the nurse to perform a slow code and to let the client rest in peace. If she stops breathing, how should the nurse respond?
Profe, so I understand the question. The patient already has a DNR
No,
on place.
no, but because look what it says. Physician enforce, okay, enters that the husband of an unconscious client with terminal cancer will not grant permission for the not resuscitate order. So the husband of the unconscious client, so the husband of the patient is not agree with DNR. Got it? And the physician tells the nurse to perform a slow code and let the client rest in peace. If she stops breathing, how should the nurse respond?
No, rest in peace if she stops breathing. How should the nurse respond?
What is a slow code to begin with?
Slow. I never heard about slow code.
Me
A
neither.
slow code, it's very similar, okay, to not resuscitate, okay, and it's very similar to that. It's like allow the patient to to die. Okay, it's something that okay refers to the practicing hospital and other medical centers to respond really slowly to incomplete patient cardiac arrest. That's what it means, a slow code. Particularly in situations in which cardiopulmonary CPR, it's turned not to be a medical benefit for the medical staff. So, which in other words, the family doesn't want to be DNR, and you, because you are the doctor, and you decide that the patient is having a cardiac arrest, you will allow the patient to die, okay, little by little.
So
That
the
one
answer
is a
is
slow
D.
code. Huh?
The answer is D here.
Tell the physician that if the client stop breathing, the physician will call before other actions are taken. Read carefully. Just remember, family is refusing. DNR. Can you do
D.
something without talking to the family with someone that is unconscious? In this type of questions, can you do something without talking to the husband first?
Yeah, of course no. No.
You cannot.
Okay. Because you know, that is completely legal.
But Prophet, the patient has a signed DNR order in his file. That's what he's
No,
saying
no,
over
no, no,
there,
no,
right?
no, no, no. Look what it says right there.
That's what I don't understand. My
A
understanding
physician
is
informed
that
a
the
nurse
wife.
that a husband of the unconscious client with terminal cancer will not grant permission, not dando permiso, will not grant permission for a DNR order.
Then it's A.
Yeah, I thought
Claro.
that she was trying to um omit the DNR order that is already in place.
No, no, no,
Telling
no,
the
no.
doctor, no,
Just,
doctor,
no,
resuscitate.
no. He's
That's what I thought.
unconscious. The patient cannot decide anything by themselves right now. So the one that has to decide, the husband, that is the first spouse, the first king in the list right there.
Yes,
So with
exactly.
terminal cancer, he said, we're not grant permission. I'm not going to give permission for DNR order. But besides that, the physician says, well, you know what? Perform a slow code to her and let her rest in peace and just stop breathing on, the physician, okay, telling the physician that slow codes are not acceptable. Because if the family member doesn't want to implement DNR, how you cannot implement a slow code to patient when your family members actually doesn't not even agree with the DNR?
But I thought that the DNR is a decision of the patient.
And the proxy. If the patient is unconscious, okay, the closest family member decides by the patient. Is it has to be DNR or not? Got it?
Yeah, I was confused. I don't know.
Yeah. Yeah, the patient is unconscious, but who will decide if the patient will be DNR or not? Okay, the husband. Now you have to go to the closest one.
Yeah.
No,
No, I
always.
understand that. Yeah. I understood
Oh,
that
wait,
the
go to the
DNR was
spouse
already in
first.
place, and she wants the doctor to forget about the DNR and resuscitate him.
Yeah. How do you want me to give a slow code to the patient? Is actually not even the family is agree with the DNR. Got it. ¿Cómo lo voy a dejar así que se muera lento a lento cuando realmente the husband is not even agree with the DNR?
No, I understand. I understand English. I know.
Got it. And a slow code is something, okay, purposeless. Got it. It purposely you induce the patient in a slow code. Okay, because you believe that the patient needs to die in peace, you're gonna put it in a slow code. Got it? What I'm saying? It's something that they practice in the hospital and other medical centers to purposely respond slowly to the incomplete to a patient cardiac arrest. But for that, you need to have a family concern. Got it?
Yes.
And it's not.
Why is the answer?
Hey,
Oh,
I would say, I would talk, okay, to the husband first. If he's agree, okay, to put his wife in a slow code. That would be, before I put it, before I follow Dr. Lawrence, I would say, well, let me talk to the husband first because I cannot do anything like without, talking or ask for permission. Okay? So that in completely impair any kind of aggressive intervention you can do to bring the patient back. Got it what I'm saying?
Yeah, I understand.
So it means the patient needs DNR, you're not gonna do it because, or the patient needs another get 2 for intubation or something, you're not gonna do it because he's in a slow code. Because that immediately, okay, affects any kind of intervention you would do to bring the patient back. And actually the husband says, no, I don't want DNR. So me resuscitate my wife. So. Got it? Okay, guys, I'm sorry, we finished just for today. I hope that you like the review. Okay?
Yeah, very good.
Thank you.
Thank you very much.
Thank you,
Yeah,
Prof.
before you leave, let me download attendance, okay, for you from Teams. Okay, just in case they ask me. Fine. So next week we're gonna go, okay, over we're gonna go over the
Infection.
chest tube and infection control. Okay.
Okay, perfect.
Okay, thank you.
Thank you. Night.
Bye bye.
No, Professor.
Bye bye. Hoy 17. ¿Llegaste con la menstruación o todavía? Estás acá, ¿no?